Chapter 1. Patient interviewing. Types of interview. Initial history and mental state examination. A large proportion of the task will be to find out facts. This does not mean that you should just inquire about dates and events in a person's life, or you will also want to know the emotional significance of certain events for a patient. Or at the end of the interview, you should be able to make a differential diagnosis. Or it is important from the beginning to consider the extent to which you will need to promote compliance. To make the correct diagnosis is usually insufficient if your patient does not return to the follow-up interview or does not comply with the appropriate treatment. Or the purpose of these interviews varies enormously. In a follow-up interview, you may want to clarify certain areas that you did not get around to asking about, or only briefly touched upon, in the first interview. In order to obtain further diagnostic information, you may want to initiate treatment or to monitor a patient's mental state in order to assess their response to treatment. You may want to check whether a patient has any difficulties in following a treatment program and whether they have understood your explanation for their symptoms. You may want to give the patient the chance to ventilate their feelings about a problem. Or it is always important to have an agenda, no matter how small, in your mind when you see a patient. Otherwise, you are just conducting an unfocused chat. Or these are specialized assessment interviews. Or their main purpose is to understand how patients function emotionally, what coping and defense mechanisms they use, and how they relate to others and to themselves. Or although psychoanalytical processes may have an important role in general medical and psychiatric practice, they have a special importance in psychoanalytical psychotherapy assessment interviews. Follow-up interview. Psychoanalytical interviews. Ground rules. The setting of the interview. Or try to see patients in a quiet room where you will not be disturbed and where confidentiality can be maintained. Or try not to see patients in a busy dormitory on the ward. Or interruptions by ringing telephones or people coming into the room are not conducive to creating an atmosphere in which patients can talk openly about themselves. Or it is best to talk to a patient when both you and the patient are sitting on chairs of roughly the same height. If you sit on a chair much higher than the patient, they can feel you are looking down on them. Conversely, if you give them a higher chair, you may feel exposed and uncomfortable. Or chairs are best arranged at a 120-130 degrees angle to each other. This gives patients the chance to make eye contact or to avoid it, whichever they feel most comfortable with. Or if you sit directly opposite the patient, they may feel stared at. Or avoid making detailed notes during an interview with a patient because it can be distracting for the patient and may promote suspicion about what you are writing. Or look at the patient when you ask a new question, or acknowledge that you have taken in their answers by looking at them. Otherwise, they may get the impression that you are more interested in your notes than in them. Or an hour and a half is about the maximum duration for an interview. After that, your concentration and that of the patient will diminish. Or some patients find interviews of 10-15 minutes too much. This may be because they are distractible, tired, distressed, or angry, or because they are avoiding you for a different reason. Or you will have to use your judgment whether to persevere a little with the interview or to go back to the patient at another time. Or if it is the first time that you are meeting a patient, introduce yourself by name and explain what your role is within the team. Or tell the patient what the purpose of the interview is, what will happen to the information they give you, who you will share it with, and roughly how much time you intend to spend with them. Or this is the main part of the interview during which you should be able to address the issues you want to talk about. Or give patients some warning about the ending of an interview. For example, we have about another 5 minutes to talk. Or do not leave questions that are potentially upsetting to a patient to the end of an interview. Or give patients some time to ask you questions, for example about their diagnosis or treatment, etc. Seating arrangements, note taking, duration of interview, beginning an interview, the middle part of the interview, ending an interview. Page 3 of 284. Or some patients will try to make you carry on talking to them beyond the agreed time by telling you something worrying or unusual, just when you are trying to wind up. You may need to say that you will come back to this subject in the next session, or let them know when you will see them next. Or thank the patient. Information gathering and discussing treatment. Gathering information. Or the interview should begin with non-leading open questions concerning the nature of the present difficulty, followed by more focused closed questions to clarify the chronological sequences and the evolution of key symptoms. Open questions. Questions that encourage the patient to talk and are not simply answered by yes or no. For example, have you been sleeping recently? Open questions are a good way of introducing a new subject. For example, tell me about your job. The way in which a patient answers will allow you to understand what they see as important and also to identify any gaps. For example, what exactly does your job entail on a day-to-day basis? Or you mentioned that you had some difficulties with your colleagues at work. Could you give me an example? Closed questions. Questions from a checklist of symptoms which are answered by yes or no. For example, do you wake up early in the mornings? Or always phrase questions simply and clearly. Or ask one question at a time. For example, do not ask do you have problems with breathing, tingling in your fingers, or butterflies in your stomach. Or do not ask leading questions. For example, you are not suicidal, are you? Or avoid using medical jargon yourself. Or if your patient uses a medical term, check to see what they mean. They may have a very different understanding of the term. Or give patients time to answer and listen to their answers. Or do not let patients steer you away from a subject. If you feel you have not got a full picture of some of their difficulties, tell them so and ask further clarifying questions. Initiating and monitoring treatment. Or this will usually involve a period of discussion about about the nature of the problem that you have been discussing, or when you provide information, try and keep it at an appropriate level for the patient's background, or avoid jargon, or ask your patient to summarize what you have been trying to explain, so that you can make sure they have understood, or in subsequent interviews, explain in detail about the treatment regime, or inquire if there are any problems with the treatment. Interview techniques. Empathy. Sharing another person's suffering by putting oneself in their shoes. For example, I expect you are quite nervous about the operation. They can be a bit nerve-wracking. That must have been difficult for you. Sympathy. A feeling of recognition of another person's suffering. With sympathy, you feel sorry for the person, but you do not necessarily understand what they are actually feeling, versus empathy. For example, I am sorry that you are upset. Clarification. Asking for more information. What do you mean when you said that you had a panic attack? Confrontation. For example, in spite of my advice on the dangers of smoking, you still continue to smoke. Facilitation. Encouragement of the patient to elaborate further. For example, can you tell me more about that? Reflection. A response by the interviewer that repeats or echoes some of what the patient has already said. For example, patient: I thought that I was going to die when I had the panic attack. Doctor: you thought that you were going to die. Silence. A useful technique that gives the person time to express deeper thoughts and emotions. Summation. Reviewing the information that has been given by the patient. For example, before we talk about your depression, can I just go through what you have told me about your panic attacks? Please correct me as I go along. Special problems. Talking about difficult topics, or topics such as a person's sexual history or suicidal intent. Recent bereavements and hallucinatory experiences can be very difficult to talk about and may make you feel uncomfortable. Or it is best to open up these topics with fairly general questions followed by more specific ones. You can then gauge from the response how deeply you can probe into a certain area. Or you will often find that it is a great relief for patients to be able to talk about these potentially difficult areas to someone who will listen in a sympathetic and non-judgmental way. The distressed patient. Or if a patient becomes tearful and distressed during an interview, perhaps in response to some difficult question, do not ignore this or move on to a more neutral subject. Acknowledge what is happening, or ask them gently what has made them distressed, and give them time to compose themselves again, or use your judgment to decide whether and when to carry on questioning. If in doubt, ask the patient. The discursive, waffly patient. Or some patients repeatedly wander off the point to matters only vaguely or not at all related to your questions. 6. Or it may take you a while to notice that this is happening, as some patients do it very subtly, or interrupt the patient gently but firmly and bring them back to the topic of discussion. Or the best way to interrupt is to plan an appropriate question and ask it with interest. You may need to do this repeatedly, or if a patient cannot be redirected, this may be an important diagnostic sign. Patients telling you secrets. Or in the course of an interview, some patients may say that they have never previously spoken about what they are going to tell you, or have just told you. Or they may explain that you are the only person to whom they trust sufficiently to disclose this secret, and they may ask you to keep their secret. Or while in many cases this may be a genuine show of a patient's trust in you, it may also be their way of ensuring a special relationship with you and of separating you from the remainder of the team looking after them. Or it is best to make clear to them that you work within a team and that whatever they tell you is confidential within the team. Patients talking about you. Or some patients may seem rather curious about your personal life. Or although there is no reason why you should always conceal personal information from patients, you should not automatically answer such questions, or ask yourself why they want to know something about you. Maybe it is just friendly interest. Maybe these patients are trying to deflect attention from themselves because they are worried about what you might ask them. Maybe they are trying to find out whether they have similar values or beliefs as you have, to see whether you can be trusted. Perhaps they are trying to establish your degree of professional and life experience. Some patients may try to make the relationship between them and you more equal. Others may try to undermine you by finding out personal details. You do not have to answer personal questions. Remember, the purpose of the interview is to talk about them, not you. You can point this out tactfully. Other problems. Or another tip for dealing with problems is to identify the difficulty and explore it with your patient. For example, they may be avoiding a particular issue, and whenever you ask about it, they change the subject. Or rather than leaving this issue or trying to make them answer your questions, it is often better to acknowledge the problem openly. Or try saying to your patient that you have noticed whenever this issue is brought up, they seem to change the subject and you wonder why this is happening. This may be sufficient to start a dialogue about the issue or about the reasons for being defensive. Occasionally, it may even lead you to see that your own questions were ambiguous. Patient confidentiality. Reference: Medical Council of Ireland, Guide to Professional Conduct and Ethics for Registered Medical Practitioners, 8th edition, 2016. Introduction. Confidentiality is central to the trust between you and your patients and is a core element of the doctor-patient relationship. However, sharing information in appropriate circumstances is also important, both for patient care and for the safety of the patient and others. You should protect your patient's privacy by keeping records and other information about patients securely. You should guard against accidental disclosures. Before sharing or disclosing any identifiable information about patients, you must take into account the Freedom of Information (FOI) principles. You must be clear about the purpose purpose of the disclosure and that you have the patient's consent or other legal basis for disclosing information. You must also be satisfied that, you have considered using anonymized information that does not identify the patient, and you are certain that it is necessary to use identifiable information. You are disclosing the minimum information to the minimum number of people necessary, or the person or people to whom you are disclosing the information know it is confidential and that they have their own duty of confidentiality. Disclosure with consent. Where a patient is capable of making their own decisions about their health care, you must get their consent before giving information that identifies them, or to the patient's relatives and close friends. While the concern of the patient's relatives and close friends is understandable, you must not disclose information to them without the patient's consent. If the patient does not consent, you should respect their decision, except where failure to disclose information would put the patient or others at risk of serious harm. For research, in some cases it may be possible to give coded, pseudo-anonymized data, which you can disclose without explicit consent. The Data Protection Commissioner has published a guide to using health data in research, or to disease registers with the exception of the National Cancer Registry. 7. If the patient lacks capacity to give consent and is unlikely to regain capacity, you should consider making a disclosure if it is in the patient's best interests. Most people understand and accept that information must be shared within the healthcare team and support staff to provide safe and effective care. If disclosure of a patient's information is necessary as part of their care and treatment, you should disclose the information to an appropriate person and make sure they understand that the information is confidential. You should explain to the patient that information is being shared for their benefit and with whom the information is being shared. If the patient objects to the transfer of information you consider necessary for the provision of safe care, you should explain that you cannot refer them or arrange their treatment without disclosing that information. Clinical audit, quality assurance, education and training are essential in providing safe and effective health care now and in the future. Whenever possible, information should be anonymized or coded before it is disclosed to anyone outside the healthcare team. Where this is not possible, you must make sure that the patient is told about the disclosure and given the opportunity to object. You must respect the patient's wishes. Disclosure without consent. When you disclose information as required by law or in the public interest, you should inform patients of the disclosure, unless this would cause them serious harm, or would undermine the purpose of the disclosure. Disclosure required by law. You must disclose information where this is required by law. For example, when ordered by a judge in a court of law, or by a tribunal or body established by an act of the Oireachtas Parliament in Ireland, or where required by infectious disease regulations, or where you know or have reasonable grounds for believing that a crime involving sexual assault or other violence has been committed against a child or other vulnerable person. Disclosure in the public interest. Disclosure in the public interest may be made to protect the patient, other identifiable people, or the community more widely. Before making a disclosure in the public interest, you must satisfy yourself that the possible harm the disclosure may cause the patient is outweighed by the benefits that are likely to arise for the patient or for others. You should disclose the information to an appropriate person or authority, and include only the information needed to meet the purpose. Note: in the case of Tarasoff versus Regents of the University of California, Prasenjit Poddar killed Tatiana Tarasoff. Both individuals had been students at the University of California at Berkeley. They had met a year earlier at a dancing class. After a kiss on New Year's Eve, Poddar became convinced they had a serious relationship. However, Tarasoff told him she was not interested. Poddar confided in his psychotherapist, Dr. Moore, that he was going to kill Tarasoff when she returned from summer break. Dr. Moore subsequently informed the campus police that he felt Poddar was dangerous and he should be hospitalized involuntarily. They investigated Poddar but did not consider him a risk and informed him to avoid Tarasoff. On October 27, 1969, Poddar went to Tarasoff's house and stabbed her to death with a kitchen knife. Her parents then sued the psychotherapist for failing to warn them or their daughter about the danger. The California Supreme Court rejected the psychotherapist's claim that he owed no duty to the woman because she was not his patient, holding that if a therapist determines or reasonably should have determined that a patient poses a serious danger of violence to others, he bears a duty to exercise reasonable care to protect the foreseeable victim of that danger. Disclosure after death. Patient information remains confidential even after death. If it is unclear whether the patient consented to the disclosure of information after their death, you should consider how the disclosure might benefit or cause distress to the deceased's family or carers. You should also consider the effect of disclosure on the reputation of the deceased and the purpose of the disclosure. Your discretion in this area might be limited by law. 8. Notes Chapter 1, 9. Chapter 2 Psychiatry Case Reports, 10. Chapter 2, Psychiatry Case Reports. Introduction. The components of psychiatry case reports mentioned in this chapter are discussed in greater detail in other chapters. Psychiatric history see Chapter 3. Mental state examination see Chapter 4. Physical examination, collateral history and formulation see Chapter 5. Differential diagnosis see Chapter 6. Investigations see Chapter 7. Management see Chapter 8. Prognosis see Chapter 9. Psychiatry case report headings. Psychiatric history. Introduction. Presenting difficulty. History of presenting difficulty. Past psychiatric history. Family history, parental history, siblings, family, psychiatric history, O past medical and surgical history, O alcohol and substance misuse history, O current medications, O personal history, birth and development, childhood and adolescence, education and literacy, occupational history, relations, heap history, psychosocial history, O forensic history, O premorbid personality, mental state examination, O appearance and behavior, O speech, O mood and affect, O thought, O perception, O cognition, O insight, physical examination, collateral history, formulation, O predisposing factors, O precipitating factors, O perpetuating factors, differential diagnosis, investigations, O biological, O psychological, O social, management, O biological, O psychological, O social, prognosis, O short-term factors, O long-term factors. 11. Notes Chapter 2, 12. Chapter 3 Psychiatric History, 13. O for how long have the symptoms been present? Chapter 3 Psychiatric History, Background. The psychiatric history aims to gather information in order to capture a patient's story, elicit signs and symptoms of the presenting disorder, and to derive the necessary information for diagnosis and management. Each of the individual sections of a psychiatric history should come together to give a complete picture of a patient's life and current situation. The success of a psychiatric interview depends on how well the doctor communicates with the patient. Components of a psychiatric history. Each of these components are discussed in more detail below. Introduction. Presenting difficulty. History of presenting difficulty. Past psychiatric history. Family history. O parental history. O siblings. O family psychiatric history. Past medical and surgical history. Alcohol and substance misuse history. Current medications. Personal history. O birth and development. O childhood and adolescence. O education and literacy. O occupational history. O relationship history. O psychosocial history. Forensic history. Premorbid personality. 1. Introduction. Give the patient's initials, age, gender, marital status, occupation, location, name of hospital or outpatient clinic, and the date of the patient's presentation to the hospital or outpatient clinic. Example A. Ms. BW is a 38-year-old single unemployed lady with 2 children, who presented to St. Kevin's Hospital Emergency Department on 1st October 2018. Example B. Mr. Ab is a 56-year-old married father of 3 children receiving disability benefit, who was admitted to St. Desas Hospital on 4th December 2018. Example C. Ms. SF is a 30-year-old single nulliparous woman working as a secretary, who presented to St. Joseph's Psychiatry Outpatient Clinic for a review on 6th January 2019. 2. Presenting difficulty. A concise statement giving the patient's reason for presentation. Example A. Ms. BW presented to the emergency department following an overdose of her prescription medication, which was precipitated by multiple psychosocial stresses on a background history of recurrent depressive disorder since the age of 22 years. Example B. Mr. Ad was admitted to St. Desas Hospital due to a relapse of psychosis on a background history of paranoid schizophrenia since the age of 20 years. Example C. Ms. SF presented to St. Joseph's Psychiatry Outpatient Clinic for a review with worsening generalized anxiety associated with panic attacks on a background history of post-traumatic stress disorder of 1 year duration. 3. History of presenting difficulty. This is an expansion of the presenting difficulty. O why has the patient presented now? O what were the major symptoms leading up to the current presentation? If the patient presented with depression or other psychiatric illness, consider if each of the ICD-10 criteria for depression or other relevant condition are present or absent. Also consider comorbid symptoms, for example depression, psychosis, agoraphobia, social phobia or generalized anxiety disorder by looking at the relevant ICD-10 criteria of the conditions and determining if the symptoms are present or absent. It is important to clearly describe the features of mental illness and for the main diagnosis to be obvious to someone else who reads the history of presenting difficulty. The presenting difficulty is your argument for naming the first diagnosis in your differential diagnosis as your preferred diagnosis. 14. O are the symptoms pervasive in nature, that is constantly present? If not, how frequent are the symptoms present? O were the symptoms precipitated by anything, for example bereavement, loss of one's job, etc. O are the symptoms becoming more or less intense over time? O what has been the impact of the symptoms on the patient's life? Example A of a scenario in which a patient presented to hospital following self-harm with symptoms of depression. If the patient had presented with depression without the associated self-harm, consider just the second and third paragraphs below, including a statement regarding the presence or absence of suicidal ideation in the paragraph on depression. Ms. BW presented to the emergency department following an impulsive overdose of approximately 30 tablets in total of her prescription medication comprising escitalopram, lithium and diazepam. Ms. BW said that these were all of the tablets that she had access to at home. She reported consuming 16 units of alcohol with the overdose, which she described was precipitated by an argument with her boyfriend regarding their difficult financial situation. Ms. BW denied undertaking any last acts and did not leave a suicide note. She said she was alone in the house at the time of the overdose as her boyfriend had left the house following the argument. Ms. BW said she took the overdose in her bedroom. She said she did not lock the bedroom door. Ms. BW stated that she half wanted to live and half wanted to die, but said she thought that she would die by taking the overdose. Ms. BW stated that her boyfriend returned home to find Ms. BW unconscious, lying on the bed. She said he called an ambulance which brought Ms. BW to St. Kevin's Hospital Emergency Department. On assessment, Ms. BW expressed guilt about having taken the overdose and denied any thoughts of self-harm or suicide at that time. Ms. BW described a pervasively low mood with a diurnal mood variation for the past month, which she attributed to a strained relationship relationship with her boyfriend. She described a deterioration in her sleep pattern, associated with initial insomnia and early morning wakening, sleeping approximately 4 hours per night. She described a gradual reduction in her interest in activities which she would ordinarily have enjoyed. Ms. BW stated that she had also experienced a deterioration in her energy level, concentration and appetite, eating only once per day, associated with the loss of 6 kilograms in weight over the previous 2 weeks. Ms. BW was not hopeless or helpless and was optimistic for the future. She denied any psychotic experiences such as delusions or hallucinations. Ms. BW denied any panic attacks, pervasive features of anxiety which might be suggestive of generalized anxiety disorder, or anxiety associated with crowds, public places, traveling away from home or traveling alone which might be suggestive of agoraphobia. Ms. BW also denied features of anxiety in small group settings which might suggest social phobia. Example B. Mr. Ad was referred to Street Disas Hospital for aid admission under the Mental Health Act 2001 by her community mental health team. Over the month leading up to his aid admission, Mr. Ad described experiencing third-person auditory hallucinations, command hallucinations, delusions of persecution and thought echo. Mr. Ad notably discontinued his prescribed antipsychotic medication during this time and had disengaged from the community mental health service. During the month leading up to his aid admission, Mr. Ad described becoming increasingly distressed by third-person auditory hallucinations of increasing intensity throughout the day, comprising the voices of his family and the staff of the community mental health service who repeatedly stated he is going to die and would command Mr. Ad to throw various items across the room at home. Mr. Ad denied command hallucinations to harm himself or others. He described his thoughts echoing after he would think them. Mr. Ad became concerned for his safety and believed with delusional intensity that he was being followed and that his movements were under constant surveillance by his family and the staff of the community mental health service. He was also very distressed by evil thoughts which Mr. Ad believed that his family and the community mental health team were putting into his head. Mr. Ad denied thought withdrawal or broadcasting and did not report delusions of control, influence or passivity, or delusional perception. Mr. Ad's family telephoned the community mental health service to inform them of his deteriorating mental state. They assisted Mr. Ad's family in having Mr. Ad transferred to Street Disas Hospital. Mr. Ad denied any pervasive mood disturbance, reduced interest or enjoyment, or any reduction in his energy, concentration, self-esteem, sleep or appetite. He did not report ideas of guilt and unworthiness, or a pessimistic view of the future. He denied any thoughts of self-harm or thoughts of harming others. Mr. Ad denied any panic attacks, pervasive features of anxiety which might be suggestive of generalized anxiety disorder or anxiety associated with crowds, public places, traveling away from home or traveling alone which might be suggestive of agoraphobia. Mr. Ad also denied features of anxiety in small group settings which might suggest social phobia. Example C. Ms. SF described an increase in the frequency of her panic attacks over the past 6 months, associated with increased pressure in her secretarial job. She stated that she first began to experience panic attacks 1 year ago following a serious car accident in which a lorry crashed into her car, killing her husband who was driving the car. Initially, the panic attacks occurred once daily and would last up to 1 minute in duration. For the past 4 months, Ms. SF stated that she had been experiencing panic attacks of up to 20 minutes in duration, up to 5 times daily, and that they were not relieved by relaxation or deep breathing techniques. She said she last experienced a panic attack 1 hour prior to the current review. During a typical panic attack, Ms. SF stated that she would experience shortness of breath, sweating, palpitations, dizziness, extreme terror and the belief that she was going to die. 15. Ms. SF also described worsening apprehension, motor tension and autonomic overactivity over the past 6 months. She did not report anxiety associated with crowds, public places, traveling away from home or traveling alone which might be suggestive of agoraphobia. Ms. SF also denied features of anxiety in small group settings which might suggest social phobia. She described experiencing daily flashbacks of the car crash which started 6 months ago, associated with numbness, emotional blunting, detachment from other people, unresponsiveness to her surroundings, lack of pleasure in activities she would usually enjoy, avoidance of activities and situations reminiscent of the trauma, autonomic hyperactivity with hypervigilance, enhanced startle reaction and insomnia. Ms. SF denied any pervasive mood disturbance, reduced interest or enjoyment, or any reduction in her energy, concentration, self-esteem or appetite. She did not report ideas of guilt and unworthiness, or a pessimistic view of the future. She denied any thoughts of self-harm or thoughts of harming others. She did not report any psychotic symptoms such as delusions or hallucinations. 4. Past psychiatric history. Does the patient have a history of previous contact with a psychiatric service, or at what age was the patient diagnosed with mental illness, or who diagnosed the patient with mental illness, or what diagnosis was made, or number of previous admissions to a psychiatric hospital and the reasons for such admissions, or average length of admissions, or when was the most recent admission, or any involuntary admissions, or has the patient ever been treated with electroconvulsive therapy ECT. If the patient currently has depression, do they have a past history of hypomania or mania? Does the patient have a past history of self-harm, or how many previous episodes of self-harm has the patient had, or when was the first episode of self-harm, or when was the most recent episode of self-harm, or what forms of self-harm have been undertaken? For example, Example: overdose, self-laceration, attempted hanging, attempted drowning, etc. Did the patient require stitches or other medical attention following any episode of self-harm? Example: Ms. BW was referred by her GP to Millgrove Mental Health Service at the age of 22 years with a deterioration in her mood, appetite, energy and level of interest in activities. In the context of feeling under pressure with her university coursework, she was diagnosed with depression by the mental health service at that time. Ms. BW has been followed up at regular intervals in the psychiatry outpatient clinic since her referral. Ms. BW described a history of 6 inpatient psychiatric admissions for depression. She stated that her average length of admission had been between 2 to 4 weeks in duration, the longest admission at the age of 28 years, having been under the Mental Health Act 2001. Ms. BW stated that she had a history of 4 past episodes of self-harm, 3 overdoses and 1 laceration of her wrist which were impulsive in nature. She stated that her first episode of self-harm was at the age of 22 years, the most recent episode having been 12 months ago when she was aged 32 years. She stated that she received stitches to her left wrist following her most recent episode of self-harm. She denied any history of elevated mood which might be suggestive of hypomania or mania. 5. Family history. Parental history. What age are the patient's parents or their age when they died and the cause of their death? What are the occupations of the patient's parents? If the parents are separated or divorced, when did they separate or divorce? How would the patient describe their relationship with their parents? Siblings. How many siblings does the patient have? What is the age range of the patient's siblings? If any siblings are deceased, what age were they when they died? When did they die and what was the reason for their death? What position in the sibship is the person? How would the patient describe their relationship with their siblings? Family psychiatric history. Is there any family history of psychiatric illness in the immediate and distant family? Do any family members have a history of inpatient psychiatric admission? Is there any known family history of self-harm or suicide? Example: parental history. Ms. BW said her father was 68 years old and worked as a carpenter. She reported that her mother was 66 years old and was a housewife. Ms. BW described a lifetime good relationship with her parents' siblings. Ms. BW stated that she had 4 siblings, 3 sisters and 1 brother, ranging in age between 30 to 40 years. Ms. BW said she was the second eldest in the sibship. She described a distant relationship with her siblings. 16. Family psychiatric history. Ms. BW reported that her mother had a history of depression, for which she was attending a mental health service. Ms. BW said her mother had a history of 2 inpatient psychiatric admissions and 1 episode of self-harm, attempted hanging. The latter happened 5 years ago. Ms. BW reported that her brother had a history of alcohol dependency and heroin misuse. 6. Past medical and surgical history. Does the patient have a history of epilepsy, diabetes, asthma, head injury or any other significant medical illness? Does the patient have a history of any operations? Does the patient have a history of an allergic reaction to any medication? Example: Ms. BW denied a history of epilepsy, diabetes, asthma, head injury or other significant medical illness. Ms. BW reported that she had an appendectomy at the age of 16 years. She denied knowledge of allergies to any medications. 7. Alcohol and substance misuse history. Alcohol. What age was the patient when they first consumed alcohol? Has the level of the patient's alcohol consumption changed over time? Why does the patient consume alcohol? For example, for pleasure, escapism, euphoria, to feel normal, to reduce anxiety, to overcome withdrawals or as a compulsion in the situation when they cannot control their intake. How many units of alcohol does the patient consume per week? See chapter 24. Consider the criteria for alcohol dependency syndrome. See chapter 24. Consider the CAGE questionnaire. See chapter 24. Has the patient had any injuries under the influence of alcohol? When did the patient last consume alcohol and how many units did they take at that time? In the case of alcohol misuse dependence, does the patient have a history of engagement with any alcohol rehabilitation program? Illicit substances. Does the patient have a history of using illicit substances? What age was the patient when they started using illicit substances? Which illicit substances has the patient used? What quantity of illicit substances does the patient have a history of using? Any intravenous drug use? Has the patient ever shared needles with someone else? Why does the patient take illicit substances? For example, for pleasure, escapism, euphoria, to feel normal, to reduce anxiety, to overcome withdrawals or as a compulsion in the situation when they cannot control their intake. When did the patient last use illicit substances and what quantity of illicit substances was used at that time? In the case of illicit substance misuse dependence, does the patient have a history of engagement with any substance misuse rehabilitation program, prescription and non-prescription medication? Does the patient have a history of buying tablets such as benzodiazepines, hypnotics or olanzapine on the streets, or misusing benzodiazepines or hypnotics from other sources? Does the patient have a history of misusing prescription or non-prescription medication, head shop products? Does the patient have a history of using head shop products? Nicotine. Does the person smoke? Since what age has the patient been smoking? Number of cigarettes day. Example: Ms. BW said that she began consuming alcohol at the age of 15 years. She reported that she consumed 15 units of alcohol alcohol a week for 6 years but increased her intake to 18 units per week at the age of 21 years. Ms. BW stated that she had been consuming 28 units a week for the past 4 years. She described a strong desire to drink, difficulty in controlling her alcohol consumption, withdrawals from alcohol, neglect of her social interests in preference for alcohol consumption, tolerance and persistence with drinking despite being aware of the harmful effects. She stated that she needed an eye-opener and would drink throughout the day to overcome withdrawal symptoms. She did not feel that she needed to reduce her alcohol intake. She stated that her family had become annoyed with her about the level of her alcohol consumption. She denied feeling guilty about drinking. She reported having had one injury while intoxicated at the age of 28 years, when she fell down the stairs of her house and sustained a laceration to her leg which required stitches. Other than that, Ms. BW said that alcohol had not caused her any known medical difficulties. Ms. BW stated that she had never engaged with any alcohol rehabilitation program. Ms. BW reported that she did not have any history of using illicit substances, buying tablets on the streets, misusing prescription or non-prescription medication, or using head shop products. She said she has been smoking up to 20 cigarettes a day for the past 24 years. 17. 8. Current medications. Is the patient currently prescribed any medication? List the psychiatric medications first. O list antidepressants, antipsychotics, mood stabilizers first. O list benzodiazepines, hypnotics next. O list thyroid medication if prescribed next. O list other medications after all of the above. Do not use trade names for medications. Give the doses of the different medications and the daily frequency at which they are prescribed. How would the patient describe their compliance with their prescribed medication? For example, fully compliant, intermittently, compliant or non-compliant. If the person is not fully compliant with their prescribed medication, what is the reason for this? For example, unpleasant side effects, or the belief that they do not need the medication. Example: O escitalopram 10 mg main, O lithium 800 mg not, O diazepam 5 mg BD, O zopiclone 15 mg not, O atenolol 25 mg main, O captopril 12.5 mg main, O atorvastatin 20 mg not. Ms. BW stated that she was fully compliant with all of her prescribed medication, or Ms. BW stated that she had only been intermittently compliant with her prescribed antidepressant medication as she did not believe that she needed to take this medication. She stated that she last took her antidepressant 2 weeks ago. 9. Personal history, birth and development. O was the patient born at full gestation, premature or post mature? O was there any known instrumental intervention associated with the birth? O were there any complications associated with the pregnancy or the birth, for example umbilical cord around the neck? O where was the patient born and where did they grow up? O was the patient breastfed or bottle fed? O were the developmental milestones normally attained? Childhood and adolescence. O would the patient describe their childhood as happy or unhappy? O does the patient have a history of significant traumatic events or childhood physical, sexual, or O does the patient have a history of any significant childhood illnesses, emotional abuse? Education and literacy. O what age was the patient when they started school? O what age and what in class was the patient when they left school? O does the patient have a history of frequent changes in school? If so, why? O would the patient describe themselves as having been a good, average or weak student? O does the patient have a history of bullying? O does the patient have a history of truancy? O did the patient have a good relationship with other children and with their teachers? O did the patient have any special educational requirements? O if the patient attended second level education, did they sit the junior certificate and leaving certificate examinations? Did they pass these exams? O if the patient left school prior to completing second level education, why did the person leave? O did the patient attend third level education after leaving school? O can the patient read and write? Occupational history. O has the patient ever engaged in paid employment? O at what age did the patient start working? O what jobs has the patient worked in? O obtain the reasons if there have been frequent changes in employment. O when did the patient last work or are they still employed? O if the patient is not currently employed, what was the reason for them leaving their most? O did the patient enjoy their most recent job? O if the patient does not work, do they receive disability allowance or other social welfare? Relationship history. O quality and quantity of both romantic and non-romantic relationships. O is the patient currently married or otherwise involved in a romantic relationship? If so, for O is the patient happy in their current relationship? O does the patient have a history of any significant relationship difficulties, for example physical, sexual, school early, recent job assistance, how long, or emotional abuse? 18. O would the patient describe themselves as heterosexual, homosexual or bisexual in orientation? O does the patient have any children? If so, what are the ages and gender of the children? Psychosocial history. O what age was the patient when they left the parental home if applicable? O where is the patient currently living? O does the patient currently own their own home, live in private rented accommodation, council housing, in someone else's home, or are they homeless? O what is the current household composition? O does the person currently have any significant financial difficulties? Example: birth and development. Ms. BW said she was born full term in the Rotunda Hospital in Dublin. She was not aware of any complications associated with the pregnancy or the delivery. She reported she was bottle fed and achieved all of the normal developmental milestones childhood and adolescence. Ms. BW stated that she was relatively happy growing up. She denied any history of abuse or neglect. Ms. BW said she did not experience any significant childhood illnesses. Education and literacy. Ms. BW stated that she commenced school at the age of 4 years and left school at the age of 17 years. After passing her leaving certificate examination, she described herself as an average student who had a reasonable relationship with other children and her teachers. She denied any history of bullying or truancy. Ms. BW said she can read and write occupational history. After leaving school, Ms. BW said she worked in a variety of jobs including as a shop assistant, waitress and most recently up until the age of 22 years when she first became depressed, as a cleaner. Ms. BW said she currently receives disability allowance. Relationship history. Ms. BW described herself as heterosexual. She said she had been involved in 3 long-term romantic relationships. Ms. BW stated that she is currently single and had an 8-year-old son and a 6-year-old daughter from her most recent relations. He clustered for as Ms. BW stated Thatcher had few close friends. Psychosocial history. Ms. BW said that she lived with her parents until she moved out of the family home to live on her own at the age of 20 years. She said she currently lives with her children in a council house in Rathmines. Ms. BW denied any significant financial difficulties. 10. Forensic history. Does the patient have a history of contact with the guarde, regardless of whether or not they served a prison sentence? Has the patient ever appeared in court? If so, for what charges and what was the outcome? For example, bail, prison sentence, suspended, sentence, charges dropped. How many times has the patient been in prison either on remand or sentenced? What was the longest and shortest prison sentence that the patient has served? When was the patient most recently in prison and what were the charges? Does the patient have any charges pending? Example, Ms. BW has no known forensic history, or Ms. BW stated that she had served 2 custodial sentences for theft in the Dorchester Center of Mountjoy Prison. She said these sentences were for 3 months and 6 months respectively. Ms. BW said she was released from her most recent sentence 8 years ago at the age of 30 years. 11. Premorbid personality. This is the person's personality before they became ill and is not their current personality. The premorbid personality should be recorded in the patient's own words, using quotation marks. Example, Ms. BW described her premorbid personality as having been bubbly, sporty and outgoing. 19. Notes Chapter 3, 20. Chapter 4 Mental State Examination, 21. Chapter 4 Mental State Examination. Introduction. Mental State Examination. MSE is an examination of a patient's mental state at the time of the interview. MSE is not the same as a psychiatric history. MSE differs from a psychiatric history, which is a description of experiences prior to the interview. MSE of the brain is the equivalent of a physical examination of the body. If a patient stated that their mood was low yesterday or that they were experiencing auditory hallucinations last week, these experiences should be described in the history and not in the MSE. You should be making an assessment of a patient's mental state throughout the interview. It is misleading to think of the MSE as something you only start to do after you have finished taking the history. Information about each component of the MSE is observed or elicited by the doctor or volunteered by the patient. While you can observe whether a patient's report of low mood correlates with their presentation, they may look depressed, have hunched shoulders, establish poor eye contact and elicit clinical signs such as observed psychomotor slowness. You need to evaluate the presentation through biology of the patient's cultural and educational background. The surroundings in which a person finds themselves are useful to describe in the appearance and behavior section of the MSE. The location in which you assess someone, the person, people who were present at that time and the nature of the surroundings in which the interview took place can profoundly influence a patient's behavior. Components of the MSE. Each of these components will be discussed in more detail below. Appearance and behavior, speech, mood and affect, thought, perception, cognition, insight. 1. Appearance and behavior. Self-care, or hygiene and general self-care, or clothes, for example disheveled, unconventional, brightly colored, or skin, for example tattoos, bruising, needle marks, manner or polite, pleasant and cooperative or guarded or hostile and or irritable. Rapport, a measure of the patient's ability to communicate their feelings to another person. Eye contact, good, intermittent or no eye contact. Facial expression, motor activity, or relaxed or hyperactivity, increased motor activity that is goal-directed or agitation, motor restlessness or psychomotor retardation, reduced, slow body movements, associated with depression or stupor, loss of activity with no response to external stimuli, movements or apraxia, imitation by the patient of the interviewer's movements or tremor, rhythmic movement of part of the body or tics, repetitive stereotyped movements or sounds, for example coughing, grunting, facial twitching, shoulder shrugging or nose cramp, a characteristic facial expression in which the nose and lips are drawn together or stereotypies, repetitive voluntary non-goal-directed movements that are purposeless, for example foot tapping, body rocking, grunting, associated with schizophrenia, hyperkinetic disorder and autism or mannerisms, repetitive voluntary goal-directed movements that are purposeful, for example the extension of the little finger while holding a teacup or athetosis, a continuous stream of slow, flowing, writhing involuntary movements or chorea, repetitive, brief, jerky, rapid involuntary movements in which the resulting posture is held for a few seconds, usually affects the head, face or limbs, or hemiballismus, a type of chorea, usually involving violent, flinging involuntary movements of one arm or akathisia, unpleasant motor restlessness, worse in the lower limbs, leading to constant shifting of posture, associated with antipsychotic treatment or perseveration, senseless repetition of a previously requested movement, associated with organic disorders and, occasionally catatonia or automatic obedience. The patient does whatever is asked of them, despite being told not to do so. This cooperation may, 22. Be excessive with the patient going beyond what is asked, for example raising both arms when asked to raise one arm or waxy flexibility. Catalepsy. The patient remains in any position in which he is placed. Associated with catatonic. Schizophrenia. Note: distinguish catalepsy above from cataplexy, which describes episodes of sudden weakness that can be precipitated by heightened emotional states. Cataplexy is a flaccid paresis that is associated with narcolepsy, or posturing, voluntary assumption and maintenance of inappropriate or bizarre postures or psychological pillow. The patient holds his head a few centimeters above the bed. Associated with catatonia or mitmachan. A person who, despite instructions to resist movements, allows an extremity to be placed in any position without resistance and returns the body part to the original resting position once the interviewer releases the extremity, versus waxy flexibility, in which the person retains the position in which the body is placed, or mitjahan, an extreme form of mitmachan in which there are exaggerated movements in response to light finger pressure despite instructions to the contrary, or negativism, an apparently motiveless resistance to all instructions or attempts to be moved, or movement in the opposite direction, or forced grasping. The interviewer's offered hand is repeatedly grasped and shaken despite requests not to do so. Associated with the frontal lobe lesion. 2. Speech. Aphonia. Loss of the ability to speak. Stammering. Stuttering. The flow of speech is broken by pauses, with the repetition of parts of words. Pressure of speech. Increased rate of speech. Associated with hypomania and mania. Poverty of speech. Decreased rate of speech. Associated with depression. Coprolalia. Obscene verbalizations. Associated with Tourette syndrome. Neologisms. Creation of new words or phrases which only have meaning to the patient. Associated with schizophrenia and autism. Metonyms. Word approximations. For example, papascut for a pen. Echalalia. Imitation by the patient of the interviewer's words or phrases. Perseveration. Senseless repetition of a previously requested response. For example, oh doctor, where do you live, patient? Double in. Doctor, what age are you, patient? Double in. Palilalia. Perseverated word is repeated with increasing frequency. Logoclonia. Perseveration of the last syllable of the last word. Associated with Alzheimer's disease. Clanging. Clang associations. Linking words together based on similar sounds rather than coherent meaning. Associated with psychosis and mania, or associated with the initial syllable of words in schizophrenia, or associated with the last syllable of words in mania. Word salad. Schizophasia. A jumble of words that are not apparently linked and may be difficult. 3. Mood and affect. Mood. A sustained emotion versus affect, an emotional response usually triggered by a stimulus. Mood. Note: mood in the MSE has both objective and subjective components. To understand: euthemic, normal mood or depression, lowered mood or elation, elevated mood or emotional lability, a rapid fluctuation in the mood from one extreme, for example normal, to another, for example low anti-affl or anxiety, a sense of fear or dread or irritability, easily annoyed with a liability to angry outbursts. Associated with hypomania, mania or alexithymia, difficulty describing one's emotions. Associated with somatization disorder or perplexity, anxious or puzzled bewilderment. Associated with schizophrenia, affect or flattened, reduced range of emotion. Associated with schizophrenia or blunted, loss of a range of emotion. Associated with schizophrenia. 4. Thought. A. Thought content. Thoughts of harming oneself or others. Obsession. Involuntary, intrusive, unwanted thoughts, doubts, impulses or images despite the person's recognition of their senseless nature and resistance to them. The individual recognizes these thoughts as their own versus thought. Insertion वही author person believes that thoughts from an outside agent are being put into the head. Overvalued idea. An unreasonable and sustained belief that is maintained with less than delusional intensity. That is, the person with an overvalued idea is able to acknowledge the possibility that the belief may not be true, versus a delusion in which the person is convinced their belief is true. May be seen in ordinary people in the absence of. 23. Mental physical illness delusion, a fixed, false, unshackleable belief held in the face of evidence to the contrary, that is out of keeping with an individual's social and cultural background. Note: a delusion is not amenable to persuasion and is therefore not dispelled by argument or primary delusion. True delusions, which are characteristic of schizophrenia, arises spontaneously and can be further divided into delusional perception and the autochthonous delusion, sudden delusion with no prior basis, which arises in the absence of any external stimulus. Delusional perception is the attribution of a new meaning to a normally perceived object. For example, a man was offered sugar in his tea, and because it was white he immediately took this to mean that he would inherit the throne. A patient who saw a dog lifting his paw instantly knew that this lifted paw indicated an approaching apocalypse. Both types of primary delusion can be preceded by a delusional mood in which the patient has the conviction that there is something odd going on around them which concerns the patient themselves, but they do not know what it is. They may be fearful, apprehensive or perplexed until the delusion or delusional perception suddenly occurs. These true delusions are said to be non-understandable from our normal empathic stance. They are psychologically irreducible in the sense that we cannot readily understand them as originating in particular affects, instincts or fears. Or secondary delusion, delusion-like ideas, can be understood as arising from some other morbid experience. For example, delusions, often primary delusions, mood disorders, perceptual disturbances and other abnormal phenomena such as passivity experiences giving rise to delusions of control. Secondary delusions are accessible to empathic understanding and they make sense in the light of affects and other experiences the patient had prior to the delusional manifestation. Or delusion of persecution, delusion of being harassed, persecuted or conspired against. For example, the FBI constantly following me. Associated with schizophrenia, psychotic depression and mania with psychosis, or delusion of reference, a delusion that ordinary events, objects or behavior of others have particular and unusual meanings specifically for oneself. For example, the red car parked outside my house meant that I should cook dinner. Some of what is said on the television and the radio is about me. Associated with schizophrenia, psychotic depression and mania with psychosis. Note, when beliefs similar to a delusion of reference are held with less than delusional intensity, they are termed ideas of reference. Ideas of reference can occur in the absence of mental illness, or delusion of poverty, delusion that one is in poverty, or delusion of grandeur, delusion of exaggerated importance, power or identity. For example, my ideas are world class, nobody is as clever as me. Associated with mania or delusion of guilt, I am a pedophile, I deserve to be punished. Associated with psychotic depression or nihilistic delusion, the world is over, I am dead, my bowel skin is rotting. Associated with psychotic depression or delusion of infidelity, delusional jealousy, morbid jealousy, Othello syndrome, delusion that one's lover is sexually unfaithful, or delusion of love erotomania, de Clerambault's syndrome, delusion that someone of a usually higher standing is in love with them. For example, I love Leonardo DiCaprio, I write to him every day, I know that he loves me from the way he scratched his left ear in his latest film. Or delusion of infestation, Ekbom's syndrome, the person believes that their skin and or eyes are colonized by parasites. Or delusion of doubles, Capgras syndrome, delusion that a person known to the patient has been replaced by a double. Passivity experiences Omade thoughts, thought insertion, the patient believes that some of his thoughts are not his own and are being placed in his head by an external agent. Thought withdrawal, the patient believes that some of his thoughts are being removed from his head against his will. Thought broadcasting, the patient believes that his thoughts are known to other people who can read his thoughts. Omade acts and impulses, the patient believes they are being made to do something under another person's control. Omade movements, the patient believes that their arms or legs are moving under another person's control. Omade emotions, the patient believes that they are experiencing someone else's emotions. B. Thought form, thought blocking, regular interruptions in the stream of thought. Objective signs are abrupt, repeated interruptions in the flow of conversation. Subjective experience is that of a total, uncontrollable emptying of the mind. Associated with schizophrenia, fusion, various thoughts are fused together, leading to a loss of goal direction. Substitution, one thought fills the gap for another appropriate thought. Circumstantiality, speech that is very indirect and delayed in reaching the point due to the inclusion of unnecessary detail. Tangentiality, speech that never reaches the point versus circumstantiality, flight of ideas, the person's thoughts and conversation move quickly from one topic to another, so that one train of thought is not completed before another appears. Associated with hypomania, mania, loosening of associations, a disturbance of thinking shown by speech in which ideas shift from one subject to another. 24. 30 unrelated or minimally related thought. First, associated with schizophrenia, or types of loosening of association, night smooth thinking or derailment, or tangential associations between ideas. The move of the night in chase is used as a metaphor for the unexpected and illogical connections between ideas talking past the point. Vobiridon, the patient seems to get close to the point of discussion, but skirts around it and never actually reaches it. Verbigeration equals word salad equals schizophasia equals paraphrasia. Speech is reduced to a senseless repetition of sounds and phrases. 5. Perception, sensory distortion, real objects are perceived as altered in some way. Omicrasia, objects are seen as smaller or further away than is actually the case. Omacrosia, objects are seen as larger or nearer than is actually the case. Dysmegalopsia, objects are seen as altered in shape. Illusion, a false perception of a real external stimulus, for example seeing shapes in cloud patterns. Or hallucination, a false perception in the absence of a real external stimulus. Or a true hallucination occurs in outer external objective space outside my head. It has the same quality as normal perceptions, for example vivid, solid, and is not subject to conscious manipulation. Or a pseudo hallucination occurs in inner subjective space inside my head. It lacks the quality of normal perceptions, but like a true hallucination is not subject to conscious control or manipulation. Note, hallucinations are not confined to the mentally ill and can occur in the absence of mental illness. For example, hearing your name called very clearly in a shop. People who have been recently bereaved or are overtired can experience hallucinations. Note, pseudo hallucinations do not occur during dreams. Note, pseudo hallucinations are not pathognomonic of any illness. Auditory hallucination involves the sense of hearing. Second person auditory hallucination in the second person. For example, you are a bad person. Third person auditory hallucination in the third person. For example, he is a bad person. Running commentary on the person's behavior as it occurs. For example, she is showering, she is opening the door, she is entering the house. Command hallucinations, the voices instruct the person to do something. For example, kill that baby. Visual hallucination involves the sense of sight. Lilliputian hallucination, visual hallucinations of small people or small animals. Lilliputian refers to the little people who lived fictionally on the island of Lilliput in Jonathan Swift's book Gulliver's Travels. associated with withdrawal from alcohol. Note: first consider an organic cause. If someone describes visual hallucinations or olfactory hallucination, involves the sense of smell or gustatory hallucination, involves the sense of taste or tactile, haptic hallucination, involves the sense of touch, often associated with illicit substance use, such as in someone who feels bugs crawling on their skin, known as formication after a prolonged period of cocaine or amphetamine use, or kinesthetic hallucination, a hallucination involving the sense of bodily movement, for example feeling that one's limbs are twisted, associated with schizophrenia or somatic hallucination, the perception of a physical experience localized within the body, for example a feeling of electricity or feeling that one's intestines are twisted, or hypnagogic hallucination, a vivid dream-like hallucination at the onset of sleep. Note: hypnagogic hallucinations occur when going to sleep, or hypnopompic hallucination, a vivid dream-like hallucination on awakening from sleep, or extracampine hallucination, hallucination of an external object beyond the normal range of perception of the sensory organs, for example hearing a voice in China when one is in Ireland, or functional hallucination, hallucinations in one modality of sensation which occur after experiencing a normal stimulus in the same modality of sensation, for example a patient who experiences auditory hallucinations when he hears the sound of the hospital's air conditioning, that or reflex hallucination, synesthesia, hallucinations in one modality of sensation which occur after experiencing a normal stimulus in another modality of sensation, for example seeing the face of God after hearing the doorbell ring, that or elementary hallucination, hallucinatory experiences of simple sensory elements, for example flashes of light or unstructured noises such as rustling of leaves, depersonalization, the person feels that his own feelings and or experiences are detached, distant or not his own, derealization, objects, people and or surroundings seem unreal, distant, artificial, colorless or lifeless. 6. Cognition, level of consciousness, o alert, o clouded, o drowsy, o stupor. 25. Page 23 of 284. O coma orientation, O time, whether the patient can identify the day, date and approximate time of day or place, whether the patient can identify where they are, O person, whether the patient can identify who they are, who their interviewer is and the names of the people that they come into contact with. Concentration, O ask the patient to continue to subtract 7 from 100. Memory, O long-term memory, in what year were you born, what year did you finish school, how long have you been married, what ages are your children. O short-term memory, ask the patient to repeat a fictional name and address, for example, Mr. John Smith lives in apartment 157B, Jackson Gate Drive, Dundee, Scotland. Digit span, ask the patient to repeat a series of digits both forward and backwards, starting with 5 numbers and building up to 7. Mini mental state examination, MMSE, Montreal cognitive assessment, clock drawing test. 7. Insight. Does the patient believe he is suffering from a mental illness? Does the patient believe he needs treatment? Does the patient believe that he needs to be in hospital? Note: insight is not an all or nothing phenomenon. Mental state examination template answer, appearance and behavior. Mr. X presented as a casually dressed, well-groomed gentleman with satisfactory personal hygiene. He was cooperative, established good rapport and made reasonable eye contact. Mr. X appeared calm and relaxed with no evident mannerisms or other disturbances in movement. He was not tremulous or obviously intoxicated and did not present as being oversedated. Speech was normal in rate, volume and tone, and was both coherent and relevant. Mood. He described his mood as being happy. Objectively, his mood was euthemic. There was no objective evidence of depression, elation or anxiety. Thought. He denied any ideas, thoughts or plans of self-harm and stated that life was worth living. Mr. X denied any ideas, thoughts, or plans to harm any other person. He denied any passivity of thought, including thought insertion, thought withdrawal, thought echo or thought broadcasting. There was no evidence of delusional thinking and he did not display any paranoid ideation. There was no evidence of any formal thought disorder. Stream of thought was normal. Obsessional thinking was not evident. Perception. He denied hallucinations in all modalities and other perceptual abnormalities such as depersonalization or derealization. Mr. X denied any unusual religious experiences. He denied any concerns regarding the television or the radio. Cognition. He was orientated in time, place and person. His concentration levels and attention span were normal. No disturbances in short-term or long-term memory were elicited. He scored 29/30 on the MMSE Insight. Mr. X stated that he did not suffer from a mental illness and that he did not have a significant problem with alcohol or illicit substances. He stated that he did not feel that he would benefit from alcohol or substance misuse counseling. Mr. X had limited insight with regards to the need to remain in hospital and receive treatment. He denied any benefit from his prescribed medication. If the person was suffering from depression, anxiety, hypomania, mania at the time of the interview, list the evident signs, symptoms of these disorders. For example, 1. Depression, underthought, presence or absence of reduced self-esteem and self-confidence, ideas of guilt and unworthiness, and oblique and pessimistic views of the future. 2. Hypomania, mania, under appearance and behavior, presence, absence of over-familiarity and irritability, under speech, presence, absence of pressure of speech, under thought, presence, absence of inflated self-esteem and grandiose ideas, under cognition, presence, absence of distractibility. 3. Anxiety, under appearance and behavior, presence, absence of trembling, sweaty palms and or difficulty sitting still during the interview, under thought, presence or absence of obsessional thinking. 26. Page 24 of 284. Notes chapter 4, 27. Page 25 of 284. Chapter 5. Physical examination, collateral history and formulation. 28. Page 26 of 284. Physical examination. Chapter 5. Physical examination, collateral history and formulation. Are the vital signs within normal limits? Is there physical evidence of self-harm such as lacerations or burns recent or healed? Is there physical evidence of organic pathology? Is there visible evidence of needle track marks? Examine the relevant body system. For example, nervous system examination if the patient is prescribed antipsychotics in order to outrule extrapyramidal side effects. Thyroid examination if the patient presents with hypomania, mania or depression. Example, vital signs were within normal limits. There was no physical evidence of self-inflicted lacerations or organic illness such as thyroid pathology. There was no observed evidence of side effects to psychotropic medication such as rigidity or tremor. Collateral history. Ideally, you should have collateral from other people who know the patient regarding whether the patient's reported symptoms and signs are obvious to others and if there has been any observed behavior which was of concern. Mention the source of the collateral history, for example, staff on the ward, relative, friend, doctor in the hospital or clinic, GP, patient's chart, etc. Formulation. The formulation is a short that is 4 to 6 sentences summary of the case. The relevant etiological factors can be listed in a table under the formulation. Etiological factors can be divided into biological, psychological and social, predisposing, precipitating and perpetuating factors. Biological, psychological, social, predisposing factors, antenatal difficulties, birth difficulties, genetics, family, psychiatric history, biological illness, for example thyroid, head injury, alcohol, substance misuse, use of steroids for several years, sensory loss, childhood history of abuse or neglect, relationship difficulties with parents, history of parental psychiatric illness, parental history of alcohol dependency syndrome, litigation case, physical ill health, reaction to change, for example to retirement or illness of the partner, forensic history, for example admission to the central mental hospital, institutional care, parental loss, separation, migration and loss of friends, lack of a confidant, widowed or divorced, adverse social circumstances, financial problems, poverty, underprivileged background, for example travelers, migrants, occupational problems, for example unemployment, loss of mobility, victim of theft, precipitating factors, alcohol, substance misuse, acute relapse of medical illness, head injury, infection, poor dietary intake, postpartum stopping thyroid medication, poor medication compliance, acute life events, for example bereavement, bullying, high expressed emotion, lack of insight in the case of an enduring mental illness, acute stress, for example war, misunderstanding or conflict with family, for example about treatment, alcohol or substance misuse, absence of a father figure or significant role model, perpetuating factors, ongoing illness, chronic medical illness, ongoing misuse of alcohol, illicit substances, uncontrolled thyroid dysfunction, poor medication compliance, ongoing stress, for example relationship, unresolved grief, lack of insight in the case of an enduring mental illness, preoccupation about appearance, low self-esteem, ongoing difficulties in the above listed areas, for example ongoing unemployment, financial difficulties. 29. Page 27 of 284. Notes, chapter 5, 30. Page 20. Page 28 of 284. Chapter 6, differential diagnosis. 31. Chapter 6. Differential diagnosis. Introduction. The classification of psychiatric disorders and the allocation of an appropriate diagnosis in a particular case depend on the symptoms reported by the patient. Observation through mental state examination, physical examination and collateral history. A differential diagnosis is a list of possible diagnoses. It is not just one diagnosis. List the preferred diagnosis first, and then list the other diagnoses in order of likelihood. Always consider drug alcohol misuse even if the person denies misusing drugs, alcohol and organic causes, for example, hypothyroidism in every differential diagnosis. Scenario 1. A 38-year-old woman described a pervasively low mood with a diurnal mood variation for the past month associated with tearfulness, early morning wakening, a reduction in her interest in activities which she would ordinarily have enjoyed, in addition to a reduction her energy, concentration and appetite, with the loss of 6 kilograms in weight over the previous 2 weeks. She denied any psychotic experiences such as delusions or hallucinations. Differential diagnosis. Depressive episode if this is the first episode, or recurrent depressive disorder if at least the second episode. Substance-induced mood disorder, that is mood disorder secondary to drugs, alcohol. Organic mood disorder, that is mood disorder secondary to thyroid dysfunction or other cause. Schizoaffective disorder. Scenario 2. A 28-year-old woman has been spending money excessively and is sexually disinhibited. She described a 2-week history of an elevated mood, increased energy, overactivity and decreased need for sleep. She believes that she is more important than other people. Differential diagnosis. Mania if it is the first episode, or bipolar affective disorder if it is at least the second episode. Substance-induced mood disorder, that is mood disorder secondary to drugs, alcohol. Organic mood disorder, that is mood disorder secondary to thyroid dysfunction, frontal lobe lesion or other cause. Schizoaffective disorder. Paranoid schizophrenia. Scenario 3. A 32-year-old unkempt man is brought to the emergency department. His brother reported that he has become increasingly withdrawn and his mood has deteriorated over the past month, associated with a loss of interest in activities, reduction in his sleep, appetite, concentration, energy level and self-esteem. He believes that the FBI are following him and controlling his actions. Differential diagnosis. Severe depressive episode with psychotic symptoms or bipolar affective disorder. Current episode: severe depression with psychotic symptoms if there was a previous manic hypomanic episode. Paranoid schizophrenia. Substance-induced mood disorder, that is mood disorder secondary to drugs, alcohol. Schizoaffective disorder. Organic mood disorder, that is mood disorder secondary to thyroid dysfunction, temporal lobe epilepsy or other cause. Scenario 4. A 24-year-old man described a 6-month history of social withdrawal, talking to himself, third-person auditory hallucinations, thought withdrawal and delusions of control. Differential diagnosis: paranoid schizophrenia, drug-induced psychosis, schizoaffective disorder, severe depressive episode with psychotic symptoms, organic cause, for example thyroid dysfunction, temporal lobe epilepsy. Scenario 5. A 20-year-old woman described involuntary, repetitive, unpleasant thoughts to wash her hands for the past 3 years. She recognizes the thoughts as her own and has been unsuccessful in resisting these thoughts. She washes her hands up to 80 times per day. Differential diagnosis: obsessive compulsive disorder, depressive disorder with obsessive compulsive symptoms. Schizophrenia. 40% of schizophrenia cases have symptoms of obsessive compulsive disorder. 32. Specific phobia. Alcohol substance-induced anxiety disorder. Organic cause, for example hyperparathyroidism, acute intermittent porphyria, complex partial seizures. Scenario 6. A 28-year-old man, who has been investigated many times by his GP, has presented to the local emergency department 18 times over the past 12 months with chronic abdominal pain. Repeated investigations have all been normal, but he has been unable to accept reassurances. His social and family functioning has been progressively impaired. Differential diagnosis: somatoform pain disorder, hypochondriasis, schizophrenia with somatic delusions, delusional disorder, depressive disorder with somatic symptoms, substance misuse disorder, particularly opiate narcotic addiction, factitious disorder, malingering, possibility of an as yet undiagnosed organic problem. Scenario 7. A 26-year-old man, who has been investigated many times by his GP, has presented to the local emergency department 18 times over the past 12 months with a variety of physical symptoms. Repeated investigations have all been normal, but he has been unable to accept reassurances. His social and family functioning has been progressively impaired. Differential diagnosis: somatization disorder, hypochondriasis, schizophrenia with somatic delusions, delusional disorder, depressive disorder with somatic symptoms, substance misuse disorder, factitious disorder, malingering, possibility of an as yet undiagnosed organic problem. Scenario 8. A 22-year-old man believes that he has bowel cancer and has not been reassured by repeated investigations and examinations which have all been negative. Differential diagnosis: hypochondriasis, somatization disorder, delusional disorder, depressive disorder, anxiety disorder, substance misuse disorder, factitious disorder, malingering, possibility of an as yet undiagnosed organic problem. Scenario 9. A 79-year-old female has been referred to the psychiatry outpatient clinic with progressive memory deterioration over the past 5 years. Her daughter is concerned that her mother has become increasingly neglectful of herself and her home. She recently left the gas on in the kitchen, has been found wandering around the local neighborhood on several occasions talking to herself. Differential diagnosis: dementia, Alzheimer's disease or other cause of dementia, delirium, for example secondary to dehydration, infection, alcohol intoxication withdrawal, medication toxicity, epilepsy, head injury, metabolic problem, for example diabetic ketoacidosis, CVA, hypothermia, psychotic disorder, late onset paranoid psychosis, acute psychotic episode or delusional disorder, depression, alcohol substance misuse, organic causes, for example a brain tumor, normal pressure hydrocephalus or other cause. 33. Scenario 10. A 16-year-old girl with a BMI of 17 and amenorrhea has been losing weight over the past year. She considers herself to be fat. She is described as very fussy about her food, avoids fattening foods, measures the calories she consumes and exercises excessively. Differential diagnosis: anorexia nervosa, bulimia nervosa, depressive disorder, delusional disorder characterized by hypochondriacal delusions about the body, paranoid schizophrenia, schizoaffective disorder, obsessive compulsive disorder, substance stimulant misuse disorder, organic causes, for example thyroid dysfunction, Addison's disease, Crohn's disease or other cause. Scenario 11. A 45-year-old man presented to the emergency department. He stated that he felt agitated and restless. He had been seeing rats and beetles running across the floor since the morning and believed that the FBI were following him. He has a long history of alcohol misuse. Themedically noted Thetman was confused and thatish and swear trembling. Differential diagnosis: alcohol withdrawal with delirium, delirium tremens, delirium secondary to organic cause, for example infection, CNS mass lesion, brain trauma, stroke, epilepsy, CVS, cardiac failure, arrhythmia, endocrine dysfunction, for example hypofunction of parathyroid, thyroid, liver, hepatic encephalopathy, kidney and urinary tract, uremic encephalopathy, lung hypoxia, carbon dioxide necrosis, electrolyte imbalance, post-operative, intoxication, withdrawal from medications, illicit substances, Wernicke's encephalopathy, Timothy-Korsakoff's psychosis, paranoid schizophrenia, severe depressive disorder with psychosis, mania with psychosis. Scenario 12. A 33-year-old woman has been referred by her GP. Her husband is concerned about her low mood, repeated early morning crying, weight loss and her irritability towards him and their 12-week-old baby. She has lost interest in attending to the needs of her baby. Differential diagnosis: postpartum depression, baby blues, antepartum depression which was insufficiently treated, adjustment disorder, schizoaffective disorder, postpartum psychosis, substance-induced mood disorder, that is mood disorder secondary to alcohol or illicit substances, organic mood disorder for example mood disorder secondary to thyroid dysfunction, anemia, infection or other cause. 34. Notes Chapter 6, 35. Chapter 7 Investigations, 36. Chapter 7 Investigations, Introduction Biological, O bloods, FBC, RFT, LFT, TFT, fasting glucose, B12 and folate level O. If the person is prescribed a mood stabilizer, assess the level of the mood stabilizer in the blood, to determine if it is at a therapeutic level and to evaluate medication compliance. O consider iatrogenic organic causes for the deterioration in mental health. For example, steroids can precipitate depression or hypomania, mania and levetiracetam can precipitate depression. O if there is a history of significant weight loss, calculate body mass index BMI or ECG, EEG, CT MRI brain scan if indicated or random urine drug screen supervised. Psychological or risk assessment. Types of risk to consider are shown in the table below. Risk to self, risk to others, risk from others, risk of self-neglect, risk of falls for example elderly, those with mobility difficulties, risk of alcohol substance misuse, risk to absconding from hospital, risk of non-compliance with treatment, risk to self. Differentiate between passive suicidal ideation and active plans for self-harm. Suicide. Ask about factors which may increase the risk of suicide, for example current thoughts versus plans of suicide, access to means, previous suicide attempts, alcohol substance misuse, current or previous history of psychiatric diagnosis, detailed evaluation of symptoms of depression etc., impulsivity, hopelessness, feeling a burden on others, recent losses physical, financial, personal, recent discharge from a psychiatric unit, family history of suicide, history of abuse physical, sexual, emotional, comorbid health problems, age, gender, race. Ask about protective factors which decrease the risk of suicide, for example social support, religious beliefs, sense of responsibility to children, family, life satisfaction, positive coping skills, problem solving skills, therapeutic relationship, O rating scale, if the person is cognitively impaired, mini mental state examination, MMSE, Montreal Cognitive Assessment, Mocher and the clock drawing test, assessment of frontal lobe function and discrimination between frontal dysexecutive dementia and dementia in Alzheimer's disease, frontal assessment, battery fab, neuropsychological testing to identify problem areas such as comprehension, insight and judgment, Adenbrook's cognitive examination, ASA, person presenting following an episode of self-harm or someone with suicidal ideation, tool for assessment of suicide risk or the suicide risk assessment and management manual, SRAMM, person with suspected depression, depression rating scale, for example, Beck Depression Inventory BDI or the Hamilton rating scale for depression, HAMD, person with suspected mania, Young Mania rating scale, person with schizophrenia, scale for the assessment of negative positive symptoms, SANS, SAPS, positive and negative syndrome scale, PANSS, or the 4-item positive symptom rating scale and brief negative symptom assessment, suspected anxiety, Hamilton anxiety rating scale, HAM-A, suspected obsessive compulsive disorder, Yale, Brown obsessive compulsive scale, Y-box, elderly person with suspected depression, geriatric depression scale, suspected alcohol withdrawal, Clinical Institute withdrawal assessment for alcohol, CIWA, person with a suspected eating disorder, eating attitudes test, EAT, postpartum female with suspected depression, Edinburgh postnatal depression scale, assessment of risk of violence, HCR20, O suitability for psychotherapy, social, O collateral history, for example from the person's partner, family, GP, psychiatric service, O documentation, for example, GP records, psychiatric case notes, O occupational therapy assessment of the person's needs if required, O social work assessment of the person's living circumstances, financial situation and suitability for a particular form of employment, if these areas are problematic. 37. Notes Chapter 7, 38. Chapter 8 Management, 39. Chapter 8 Management, Introduction. Management can be divided into biological, psychological and social. Tailor the management to the individual case rather than giving a general management plan which could apply to any case. Look at what medications the person is already prescribed and consider modifying the medication to manage the depression, elation, psychosis, etc. It is important not to just write antidepressant, mood stabilizer, antipsychotic under the biological management if the person is already prescribed these medications. Do not consider electroconvulsive therapy, ECT, unless all other management strategies have failed and there is a clear indication for this treatment. Example of a management plan. I would involve the multidisciplinary team in the management of this patient. I would inform his GP of the management plan. I would try to involve the family partner in the management consent needed from patient. Biological. O consider the most suitable location for management at the current time, for example inpatient, outpatient, day hospital. If inpatient treatment is required, consider if the patient can be admitted voluntarily or if there is a requirement for admission under the Mental Health Act 2001. O depressed person with a history of depression who is currently stable. Continue the antidepressant and mood stabilizer if prescribed at the current dose while continuing to monitor their mental state, response to the medication, and for the possibility of emergence of side effects. Depressed person who is not prescribed an antidepressant, consider introducing a selective serotonin reuptake inhibitor, SSRI such as fluoxetine and titrating the dose according to effect, while monitoring for any side effects to this agent. Depressed person who is already prescribed fluoxetine or other antidepressant, titrate the dose upwards, according to effect to the BNF maximum dose if required, while monitoring the person for any side effects to this agent. Depressed person who is already prescribed the BNF maximum dose of fluoxetine or other antidepressant, is compliant with the medication and has received an adequate therapeutic trial, consider switching to a different antidepressant, for example sertraline or venlafaxine, adding a mood stabilizer such as lithium or adding a second antidepressant with serotonergic properties, for example an SSRI plus mirtazapine, or an SSRI plus venlafaxine. Hypomanic manic person with a history of mania hypomania who is currently stable, maintain the mood stabilizer at the current dose while continuing to monitor their mental state, response to the medication and for the possibility of emergence of side effects. Person with acute mania hypomania, stop any prescribed antidepressant and start increase the dose of an antipsychotic, e.g. olanzapine, consider adding a short-term benzodiazepine, e.g. lorazepam or clonazepam. Psychotic person with a history of psychosis who is currently stable, continue the antipsychotic at the current dose while continuing to monitor their mental state, response to the medication and for the possibility of emergence of side effects. Psychotic person who is not prescribed an antipsychotic, start an antipsychotic such as olanzapine and titrate the dose upwards according to effect while monitoring for any side effects to this agent. Psychotic person who is already prescribed olanzapine or other antipsychotic, titrate the dose upwards, according to effect, to the BNF maximum dose if required, while monitoring the person for any side effects to this agent. Psychotic person who is already prescribed the BNF maximum dose of olanzapine or other antipsychotic, and has received a therapeutic trial, consider switching to a different antipsychotic such as risperidone. Psychotic person who has been prescribed 2 or more antipsychotics, at least one which has been an atypical agent, consider clozapine. Psychotic person with poor compliance with an oral antipsychotic, consider a depot antipsychotic, that is antipsychotic injection, or if the person is prescribed a benzodiazepine or hypnotic, aim to reduce and discontinue these agents in order to reduce the potential for dependence. Psychological or risk management or psychoeducation, for example providing education to the patient and to their partner family if possible regarding the importance of medication compliance, engagement with the psychiatric service and the person's relapse signature. Supportive therapy or cognitive behavioral therapy or dialectical behavior therapy or psychoanalytical psychotherapy. 40. Interpersonal psychotherapy or family therapy and couples therapy or mindfulness, social or alcohol substance misuse counseling, Alcoholics Anonymous AA, for people who have an alcohol problem Al-Anon, for the families of people who have an alcohol problem Al-Teen, for teenage children of people who have an alcohol problem Narcotics Anonymous NA, for people who have a substance misuse problem, social work input to assist with employment opportunities and supported accommodation if needed, or occupational therapy input to improve skills if needed, improves day-to-day living skills by focusing on components of social competence such as self-care, basic conversation, vocational skills and recreation. Social skills training teaches people about the verbal as well as the non-verbal behaviors involved in social interactions so that they can determine how to act appropriately in the company of other people in a variety of different situations. Clubhouses, program of support and opportunities for people with severe and persistent mental illness. Clubhouse participants are called members. There are no therapists or psychiatrists on staff. Programs are administered through the joint efforts of both clubhouse members and staff. Clubhouses offer an employment program designed to integrate interested members back into employment in the community. Clubhouses also offer housing support and placement, financial planning, evening and weekend social programs, continuing education support, or vocational and rehabilitation training. Supported employment involves individually tailored job placement, rapid job search and provision of ongoing job support. Eve Holdings provides programs in a wide range of career options. Daughters of Charity offers horticultural and catering vocational training programs. National Learning Network provides programs in a wide range of career options. Befriending. Isolation is a common problem for people suffering from mental illness. Befriending is the development of a relationship between a volunteer befriender and a befriendee which operates within a structural framework. This is usually a time-limited relationship which enables a person to widen their own social network, increase independence and make informed choices, so enabling them to live life to the full. Domestic violence support. Women's Aid provides information and support to women and children who are being physically, emotionally, and/or sexually abused in their own home. AMEN provides a confidential helpline and support service for male victims of domestic abuse. COSC, the National Office for the Prevention of Domestic, Sexual and Gender-Based against violence. COSC is an Irish word which means to stop or to prevent. The work of COSC covers issues relating to domestic and sexual violence against women and men, including older people in the community, refuges for women and children, MOVE Men Overcome Violence, works with men who have been violent or abusive towards their partners by helping them to take responsibility for their violence and changing their attitudes and behaviors. Or Rape Crisis Counseling, Rape Crisis Center, national organization offering a wide range of services to women and men who are affected by rape, sexual assault, sexual harassment or childhood sexual abuse. Letter Counseling Service, for adult who suffered sexual, physical or emotional abuse as children, including industrial abuse. 1 in 4, professionally supports men and women who have experienced sexual violence, many of them, during childhood. O Support Groups, Mental Health Ireland, provides care, support and friendship for the mentally ill, in addition to a Caring for Carers program. GROW, helps recovery in those who have suffered from mental illness. SHAIN, a support and patient advocacy organization for schizophrenia. O Patient Advocacy. The Irish Advocacy Network provides a peer advocacy service with people who have personal experience of mental health difficulties who have achieved a sufficient level of recovery. In the longer term, once the patient is discharged from hospital, she should be followed up in the psychiatry day hospital and subsequently in the outpatient clinic in order to monitor her mental state and compliance with her prescribed medication. Note, the biological, psychological and social management strategies given above are general options without considering any particular patient. However, it is important to tailor the management strategies to each individual patient by selecting those options which are appropriate for that case. 41. Notes Chapter 8, 42. Chapter 9 Prognosis, 43. Chapter 9, Prognosis, Introduction. Prognosis can be divided into good and bad, short-term and long-term factors. The relevant etiological factors can be listed in a table. Certain disorders have specific prognostic factors. These are discussed in the relevant chapters. Good, bad, short-term. Involvement with the psychiatric service, supportive family, supportive relationship, good psychosocial support network, desire to lead a sober lifestyle without alcohol or drugs, denied recent alcohol, substance misuse, motivated to reduce alcohol intake, compliant with medications, good insight into illness, good insight into the need for treatment, good insight into the need to remain in hospital, strong religious values, for example in a person who presented following self-harm, few friends, strained relationship with partner, family, marital disharmony, recent break up with partner, limited psychosocial support network, having to raise one's children alone, high expressed emotion at home, recent alcohol, substance misuse, not motivated to reduce alcohol intake, limited insight into alcohol, drug misuse, intermittent compliance with prescription medication, limited response to medications, limited insight into illness, limited insight into the need for treatment, limited insight into the need to remain in hospital, recurrent thoughts of suicide, current thoughts of self-harm, long-term, willing to continue engagement with the psychiatric service, long history of compliance with treatment, no known history of using alcohol, illicit substances, high level of premorbid functioning, life, long history of a poor psychosocial support network, long history of mental illness, family history of mental illness, chronic organic illness, intellectual disability and poor coping skills, long history of alcohol, substance misuse, past history of poor compliance with medication, past history of disengagement from the psychiatric services, long history of self-harm. 44. Notes Chapter 9, 45. Chapter 10 Mood Affective Disorder. 5. Persistent mood affective disorders, A. Cyclothymia, B. Dysthymia. Chapter 10 Mood affective disorders, ICD-10 classification. 1. Manic episode, A. Hypomania, B. Mania without psychotic symptoms, C. Mania with psychotic symptoms. 2. Bipolar affective disorder, A. Bipolar affective disorder, current episode hypomanic, B. Bipolar affective disorder, current episode manic without psychotic symptoms, C. Bipolar affective disorder, current episode manic with psychotic symptoms, D. Bipolar affective disorder, current episode mild or moderate depression, I. Without somatic syndrome. 2. With somatic syndrome, E. Bipolar affective disorder, current episode severe depression without psychotic symptoms, F. Bipolar affective disorder, current episode mixed, G. Bipolar affective disorder, currently in remission. 3. Depressive episode, A. Mild depressive episode, I. Without somatic syndrome. 2. With somatic syndrome, B. Moderate depressive episode, I. Without somatic syndrome. 2. With somatic syndrome, C. Severe depressive episode, I. Without psychotic symptoms. 2. With psychotic symptoms. 4. Recurrent depressive disorder, A. Recurrent depressive disorder, current episode mild, I. Without somatic syndrome. 2. With somatic syndrome, B. Recurrent depressive disorder, current episode moderate, I. Without somatic syndrome. 2. With somatic syndrome, C. Recurrent depressive disorder, current episode severe without psychotic symptoms, D. Recurrent depressive disorder, current episode severe with psychotic symptoms, E. Recurrent depressive disorder, currently in remission. 1. Manic episode, A 32-year-old woman is unable to remain seated in a chair for an assessment. Her speech is rapid and difficult to interrupt. She stated that she has been sleeping for 2 hours per night over the past week and is unable to watch television due to reduced concentration. She reported that that yesterday, she ordered €10,000 worth of new furniture and carpets for her house despite the fact that she had replaced the household furniture and carpets 4 months ago. As the interview progresses, she rushes over to the male doctor to hug him. ICD-10 criteria. All of the subdivisions of this category should be used only for a single manic episode, if previous or subsequent affective episodes. Depressive, manic or hypomanic. The disorder should. Affective disorder, ahypomania. The episode should last for at least several days on end. Be coded under bipolar. Lesser degree of mania. No hallucinations or delusions. Persistent mild elevation of mood. Increased energy and activity. Marked feelings of well-being. Increased sociability and talkativeness. Over familiarity. Increased sexual energy. Decreased need for sleep. Decreased concentration and attention. Irritability may take the place of the more usual euphoric sociability. Considerable interference with work or social activity is consistent with a diagnosis of hypomania, but if disruption is severe, 47 or complete, mania should be diagnosed. B. Mania without psychotic symptoms. The episode should last for at least 1 week. Elevated mood varying from carefree joviality to almost uncontrollable excitement. Increased energy, over activity, pressure of speech, decreased need for sleep, loss of social inhibitions, attention cannot be sustained, distractibility, increased self-esteem leading to an expression of grandiose or over-optimistic ideas. Perceptual disorders may occur. The person may embark on extravagant and impractical schemes, spend money recklessly, or become aggressive, amorous or facetious in inappropriate circumstances. In some manic episodes, the mood is irritable and suspicious rather than elated. Disruption of ordinary work and social activities more or less completely. See mania with psychotic symptoms. The clinical picture is that of a more severe form of mania as described for mania without psychotic symptoms. Delusions and hallucinations occur. Severe and sustained physical activity and excitement may result in aggression or violence. Bullet. Neglect of eating, drinking and personal hygiene may result in dangerous status of the hydration and self-neglect. Comparison between hypomania and mania. Clinical symptoms less severe. Hallucinations or delusion, not present. Hypomania, mania, more severe. Present in mania with psychotic symptoms. Work and social activities. Interference with work and social severe or complete disruption of work and social activities. 2. Bipolar affective disorder. A 28-year-old woman has a past history of 2 episodes of a pervasively depressed mood, reduced sleep and early morning wakening, reduced appetite and suicidal ideation. She also has a history of 1 episode of elevated mood, increased energy and increased self-esteem. Recovery has been complete between episodes of illness. ICD-10 criteria. Repeated, that is at least 2 episodes in which the patient's mood and activity levels are significantly disturbed. This disturbance consisting on some occasions of an elevation of mood and increased energy and activity mania or hypomania, and on others of a lowering of mood and decreased energy and activity depression. Recovery is complete between episodes. Manic episodes usually begin abruptly and last for between 2 weeks and 4 to 5 months. Median duration is about 4 months. Depressive episodes tend to last longer. Median duration is about 6 months. Note, the first episode of bipolar affective disorder in males is more frequently a manic episode, while the first episode in females is more frequently a depressive episode. 3. Depression. A 38-year-old woman presented with a pervasively depressed mood of 1 month duration. She stated that she wakes up 4 hours earlier than usual in the mornings. She has lost interest in socializing with friends and spends her days lying in bed at home. She has lost 6 kilograms in weight over the past 2 weeks. She described herself as worthless, did not believe that her situation could improve and stated that the world would be better off without her. ICD-10 criteria. A. A duration of at least 2 weeks of O depressed mood or loss of interest and enjoyment or decreased energy leading to increased fatigability and decreased activity. B. Other common symptoms or decreased concentration and attention or decreased self-esteem and self-confidence or ideas of guilt and unworthiness oblique and pessimistic views of the future or ideas or acts of self-harm or suicide or disturbed sleep or decreased appetite. 48. Severity of depression features mild at least 2 criteria from A and at least 2 criteria from B. Note, low mood is not essential for diagnosis of depression in ICD-10. Subtypes: mild depressive episode without somatic syndrome, mild depressive episode with somatic syndrome, moderate, at least 2 criteria from A and at least 3 and preferably 4 criteria from B. Moderate depressive episode without somatic syndrome, moderate depressive episode with somatic syndrome, severe, all 3 criteria from A and at least 4 criteria from B. Severe depressive episode without psychotic symptoms, severe depressive episode with psychotic symptoms. The most typical examples of the somatic symptoms are O loss of interest or pleasure in activities that are normally enjoyable, O lack of emotional reactivity to normally pleasurable surroundings and events, that is anhedonia. O waking in the morning 2 hours or more before the usual time, O depression worse in the morning, that is diurnal mood variation, O objective evidence of psychomotor retardation or agitation, O marked loss of appetite or decreased weight, often defined as 5% or more of body weight in the past month, O marked decreased libido. Note, usually this somatic syndrome is not regarded to be present unless about 4 of these symptoms are definitely present. Comparison between depression and bipolar affective disorder. Variable. Prevalence, gender, mean age of onset. Socioeconomic group, employment status, geographical region, premorbid personality, episode frequency. Etiology, biological factors. Depression, 8%. Bipolar affective disorder, 1%. Males equals females, 21 years. Increased rates in the higher socioeconomic groups, that is, I and II, associated with high rates of unemployment and job-related difficulties. Increased risk in urban areas, associated with cyclothymic personality traits, that is, repeated and sustained mood swings. Greater, before puberty. Females equals males after puberty. Females, males 2, 1. 27 years. Increased rates in the lower socioeconomic groups, that is, IV and V. Increased rates in the unemployed. Increased risk in urban areas associated with anarchistic personality traits and readiness to develop anxiety, neuroticism. Less marital status. Divorced, separated. Note, married status is a protective factor for both males and females. Divorced, never married. Note, married status is a protective factor for both males and females. Seasonal influence. Increased risk of suicide in spring and summer. Note, suicide is increased in spring and summer. Excess of manic episodes in late spring and summer. Biochemical hypothesis of depression. The monoamine hypothesis of depression refers to decreased levels of monoamines. For example, 5-HT, NA, and DA. In contrast, increased levels of monoamines may play a role in mania. Serotonin, 5-HT, decreased plasma tryptophan, decreased 5-hydroxyindolicetic acid, 5-HIAA in cerebrospinal fluid. 5-HIAA is the main metabolite of serotonin in the human body. Decreased platelet. 5-HT uptake, decreased presynaptic. 5-HT receptor concentrations, decreased cortisol response to neuron-the-crene challenge tests, decreased prolactin and growth hormone response to intravenous tryptophan, noradrenaline NA, increased platelet alpha, 2 adrenergic receptor binding dopamine DA, decreased homovanillic acid, HVA levels in cerebrospinal fluid of people with depression, 49. HVA is a metabolite of dopamine. Neuropeptides, stress hormones, decreased cerebrospinal fluid, somatostatin and neuropeptide hypercortisolemia, failure of suppression of the dexamethasone suppression test in 50-60% of people with depression, increased cortisol response to adrenocorticotropic hormone, ACTH and corticotropin releasing hormone, CRH, increased corticotropin releasing factor CRF. Note, alpha-methylparatyrosine, AMPT, decreases both dopamine and noradrenaline. This has no effect on mood in healthy subjects, but lowers the mood in people vulnerable to depression. Note, tryptophan depletion produced by drinking a mixture of amino acids that lack tryptophan has little or no effect on mood in people with no personal or family history of depression. However, unmedicated individuals with a personal history of mood disorder experience a rapid but temporary depressive relapse when exposed to tryptophan depletion. Note, antidepressants are associated with a normalization of the hypothalamic, pituitary adrenal, HPA axis or genetic factors. 5-HT1A receptor polymorphism is associated with depression. S-short allele of 5-HTT gene polymorphism is associated with depression, suicide and decreased response to SSRIs. L-long allele of 5-HTT gene is associated with increased expression of 5-HTT and increased 5-HT uptake. Heritability. Unipolar disorder, that is depression, 70%. Bipolar disorder, that is hypomania, mania and depression, 85%. Familial risk. Bipolar, unipolar, breed true. Unipolar, bipolar. Unipolar is associated with increased risk of unipolar in first-degree relatives. Bipolar is associated with increased risk of both unipolar and bipolar in relatives. Brain-derived neurotrophic factor BDNF. BDNF belongs to a family of proteins called neurotrophic factors. Neurotrophic factors are responsible for the growth and survival of nerve cells during development and for the maintenance of adult nerve cells. Although the vast majority of neurons in the mammalian brain are formed prenatally, parts of the adult brain retain the ability to grow new neurons from neural stem cells in a process known as neurogenesis. Neurotrophins erythrochemicals that help to stimulate and control neurogenesis. BDNF being only of thermostative. BDNF is downregulated in depression and is increased with successful antidepressant treatment. Developmental factors. Low birth weight, impaired neurodevelopment, low premorbid IQ is a risk factor for later development of adult schizophrenia, severe depression and schizoaffective disorder, childhood abuse or neglect, lack of parental care, parental alcohol dependency, organic risk factors for depression. Cause, example, medications, endocrine disorders, metabolic disturbances, neurological disorders, nutritional disorders, steroids, levetiracetam, rezapine, beta blockers, alpha-methyldopa, estrogens, hyperhypothyroidism, Addison's disease, Cushing's syndrome, hyperparathyroidism, diabetes, mellitus, iron deficiency anemia, hypercalcemia, hyponatremia, hypomagnesemia, stroke, subdural hematoma, brain tumors especially frontal, Huntington's disease, Parkinson's disease, multiple sclerosis, uncontrolled epilepsy, syphilis, dementia, vitamin B12 deficiency, pellagra, infections, collagen disorders, substances other, influenza, infectious mononucleosis, brucellosis, viral hepatitis, pneumonia, encephalitis vascular, systemic lupus erythematosus, scleroderma, dermatomyositis, alcohol, cocaine, amphetamines, carcinoma, chronic pain, organic risk factors for mania. Cause, example, medications, substances, psychological factors, steroids, antidepressants, levodopa, thyroxine, cocaine, ecstasy, amphetamines, excessive caffeine. Life events. Examples of risk factors for unipolar disorder: death of a spouse or a significant individual in one's life, breakup of a a relationship, losing one's job, personal illness or injury, incarceration. In some instances, there may be a direct link to external stresses, or the external pressures may serve to exacerbate some underlying genetic or biochemical predisposition. 50. High expressed emotion has been shown to increase the risk of relapse in people with depression and schizophrenia. The components of high expressed emotion are hostility, critical comments, and over-involvement. Compared to people with schizophrenia, depressed individuals are more sensitive to critical comments. The effect of critical comments, in contrast to schizophrenia, have not been shown to be alleviated by reducing the number of hours depressed people spend in contact with their relatives, or learned helplessness described by Seligman. Some people in difficult situations such as prolonged emotional, physical, or sexual abuse may begin to believe that they are powerless over their difficulties. This train of thought can lead these individuals to believe that there is nothing they can do to change their situation, which is why they do not make any attempt to do so, resulting in pessimism, apathy, and depression. Cognitive theory of depression. Beck, 1967. Cognitive triad. The person has a negative view of themselves, the world, and the future. Schemas. People who suffer from depression acquire a negative schema of the world in childhood and adolescence. Children and adolescents who suffer from depression acquire this negative schema earlier. Depressed individuals acquire such schemas through a loss of a parent, rejection by peers, or by criticism from teachers or parents. When the person with such schemas encounters a situation that resembles the original conditions of the learned schema, the negative schemas of the individual are activated. Cognitive distortions. These are systemic errors in thinking that maintain the belief of depressed individuals in negative concepts. There are four basic types of cognitive distortion. Arbitrary inference. Always drawing the worst conclusions from a situation. Selective abstraction. Focusing on the worst aspects of a situation. Overgeneralization. Drawing general conclusions about personal worth from one example. Minimization and magnification. Performance is underestimated and errors are overestimated. Personality factors. Neuroticism may increase the vulnerability for depression. Social factors. Unemployment increases the risk for depression. Location. Urban-rural for both depression and bipolar affective disorder. Brain atrophy in depression. Atrophy of the hippocampus is associated with depression. Sleep change is associated with depression. Decreased rapid eye movement REM. Sleep latency. Increased REM sleep in the early part of the night. Decreased slow wave sleep. Deep sleep, which consists of stages 3 and 4 of non-rapid eye. Disturbed sleep continuity. Middle and late insomnia and latency. Initial insomnia. Note: sleep deprivation and selective REM sleep deprivation can result in a temporary alleviation of mood. In 30-60% of cases, melatonin may be involved. Note: many antidepressants prolong REM latency and decrease REM sleep duration. Investigations. Biological. Bloods, FBC, RFT, LFT, TFT, fasting glucose, B12 and folate. ECG, EEG, CT, MRI, brain scan if indicated. DAT or random supervised urine drug screen. Psychological or risk assessment or rating scales. For depression, Beck's Depression Inventory BDI and Hamilton Rating Scale for Depression HAMD. Note: the BDI is a self-rated questionnaire while the HAMD is observer-rated. For mania, Young Mania Rating Scale. Note: the Young Mania Rating Scale is a self-rated questionnaire. Suitability for psychotherapy. Social. Collateral history from partner, family, GP. Psychiatric service if previous contact or documentation. GP records. Psychiatric case notes. Occupational therapy. Assessment of the patient's needs. Prognosis of depression. If untreated, depression may last about 6 months to several years. 70-80% of people with depression have repeated episodes, averaging 4-5 times over a lifetime. After the first episode of depression, there is a 60% chance of having a second episode. After the second episode, there is a 70% chance of having a third, and after the third episode, there is a 90% chance of having a fourth. Recurrence of depression is more likely in females than males. The frequency and length of depressive episodes increases with age. While approximately 80% of people with depression respond very positively to treatment, a significant number of movement non-REM sleep, 51. Of bipolar affective disorder. 10-15% of people with bipolar disorder end their life by suicide. The risks are highest during episodes of depression, or mixed mania. Simultaneous depression and mania. People with bipolar disorder have more episodes of illness than individuals with unipolar disorder. 4. Recurrent depressive disorder. A 40-year-old woman has had 6 episodes of mood disturbance which were characterized by pervasive depression associated with a reduction in her sleep, appetite, concentration, and level of interest in activities that she would normally enjoy. ICD-10 criteria. Repeated episodes of depression without any history of independent episodes of mood elation and over activity which fulfill the criteria of mania. If a manic episode occurs, the diagnosis should change to bipolar affective disorder. 5. Persistent mood disorders. Cyclothymia. A 34-year-old man has had numerous periods of minor reductions and elevations in his mood. He has been able to continue working during these episodes and denied a significant reduction in his productivity or level of functioning. Dysthymia. A 28-year-old woman has had numerous periods of minor reductions in her mood. She has been able to continue working during these episodes and denied a significant reduction in her productivity or level of functioning. ICD-10 criteria. A. Cyclothymia. Individuals remain treatment refractory. 5-10% of people will eventually have a manic episode and develop bipolar affective disorder. Approximately 10-15% of depressed people end their life by suicide. People with major depression have up to a 5-fold increased risk of having a myocardial infarction. Vulnerability factors. Brown and Harris, 1978, were thought to increase the risk of depression if a provoking factor life event occurred, that is, they are not causative factors. Loss of mother before the age of 11 years, having 3 or more children under the age of 14 years, lack of a confiding relationship, not working outside the home, factors associated with poor prognosis of depression. Insidious onset, early age at onset, male gender, elderly population, lower socio-economic group, that is, IV and V, neuroticism, poor morbid self-esteem, self-confidence, comorbid alcohol substance misuse, personality, physical illness, poor psychosocial support network, poor response to treatment, disorder, dysthymia, double, depression or persistent instability of mood, involving numerous periods of mild depression and mild elation, none of which have been sufficiently severe or prolonged to fulfill the criteria for bipolar affective disorder or recurrent depressive disorder. A. Dysthymia, a chronic depression of mood which does not fulfill the criteria for recurrent depressive disorder, either in terms of severity or the duration of individual episodes. Epidemiology. Variable dysthymia, cyclothymia, gender, females, males. Other conditions, males, females. 1. Seasonal affective disorder. SAD. Epidemiology, females, males. Clinical features. O. Depression commences in autumn or winter and ends in spring or summer when the hours of daylight increase. O. Atypical depressive features, hyperphagia, hypersomnia, carbohydrate craving, weight gain management. O. Light treatment on waking due to abnormal melatonin metabolism. O. Maintenance therapy should be given all winter. 52. O. Exposure to bright light should be avoided at night time. O. SSRIs can be used if needed. 2. Rapid cycling bipolar affective disorder. Definition: 4 or more depressive, manic, or mixed episodes within 12 months. Epidemiology: females, males. Management reference: NICE guideline, CG 185. Bipolar disorder, assessment and management. Published September 2014. Last updated April 2018. Offer people with rapid cycling bipolar disorder the same interventions as people with other types of bipolar disorder because there is currently no strong evidence to suggest that people with rapid cycling bipolar disorder should be treated differently. Depression bipolar affective disorder. Gender before puberty. Females equals males. Females equals males after puberty. Females, males. 2, 1. Rapid cycling bipolar. Females, males. 3, 4, 5. Double depression. Dysthymia complicated by a superimposed depressive episode. Depressive stupor. Unresponsive, akinetic, mute, and fully conscious. Following an episode, the person can recall the events that took place at the time. Grief, bereavement reaction, anger, sadness, decreased sleep, decreased appetite, decreased concentration, anhedonia, loss of pleasure in activities, restlessness, irritability, preoccupation with the deceased. Experiences the image or the voice of the deceased. The experience that one is in the presence of the deceased. Mannerisms and characteristics of the deceased may be adopted. Mummification. Behavioral change whereby the bereaved person may try to preserve the belongings of the deceased. O. Stage 3 acceptance and readjustment. Stage resolution of symptoms and acceptance. Pathological grief. Bereavement. Reaction. O. Prolonged grief reaction, lasting more than 12 months. O. Delayed grief reaction. The first stage starts after 2 weeks or later. O. Absent grief reaction. Absence of a grief reaction. O. Intense grief reaction. Symptoms are outside the normal range. Suicidalidation. Complex hallucinations other than seeing or hearing the voice of the deceased. Excessive guilt. Decreased ability to function with daily life. Risk factors for a pathological grief reaction. O. Lower socioeconomic status. O. Poor psychosocial support network. O. Unemployment. O. Sudden unexpected death. O. The survivor is coming to terms with another bereavement. O. Death of a parent, usually a mother leaving children 0, 5 or 10, 15 years old. O. Distressing or painful death. Normal grief. Bereavement reaction typically lasts 6-12 months. Mean is 6 months. O. Stage 1 stunned stage, shock, disbelief. O. Stage 2 mourning stage. 53. Notes. Chapter 10, 54. Chapter 11 Management of Depression. 55. Chapter 11 Management of Depression. 1. Biological management. 2. Psychological management. 3. Social management. 1. Biological management of depression. References. 1. NICE guideline, CG 90. Depression in adults. Recognition and treatment. Published October 2009. Last updated April 2018. 2. NICE advice KTT8. First choice antidepressant use in adults with depression or generalized anxiety disorder. Published January 2015. Last updated February 2016. 3. The Maudsley Prescribing Guidelines in Psychiatry. 13th edition, 2018. 4. British Association of Psychopharmacology, BAP, Guidelines 2015. Evidence-based guidelines for treating depressive disorders with antidepressants. A revision of the 2008 British Association for Psychopharmacology Guidelines. Introduction for people with mild depression. O. Antidepressants are not recommended as a first-line treatment in recent onset, mild depression. Active monitoring, individual guided self-help, CBT and or exercise are preferred. O. Antidepressants are not recommended for the treatment of mild depression because the risk-benefit ratio is poor for people with persistent subthreshold depressive symptoms or mild to moderate depression who have not benefited from a low intensity psychosocial intervention. Consider O an antidepressant, normally a selective serotonin reuptake inhibitor, SSRI, or O a high intensity psychological intervention, for example CBT, interpersonal therapy IPT or couples therapy, for people with moderate or severe depression. O provide a combination of antidepressant medication and a high intensity psychological intervention, CBT or IPT. When an antidepressant is to be prescribed, it should normally be a SSRI in a generic form because SSRIs are equally effective as other antidepressants and have a favorable risk-benefit ratio. If a person's depression shows no improvement after 2 to 4 weeks with the first antidepressant, check that the drug has been taken regularly and in the prescribed dose. Or if response is absent or minimal after 3 to 4 weeks of treatment with a therapeutic dose of an antidepressant, consider increasing the dose in line with the reference dose range if there are no significant side effects, or switching to another antidepressant if there are side effects, or if the person prefers when switching to another antidepressant, consider switching initially to a different SSRI or a better tolerated newer generation antidepressant, subsequently to an antidepressant of a different pharmacological class that may be less well tolerated, for example, venlafaxine, a tricyclic antidepressant, TCA, or a monoamine oxidase inhibitor, MAOI. If a person is informed about and prepared to tolerate the increased side effect burden, consider augmenting an antidepressant with a mood stabilizer such as lithium, an antipsychotic such as aripiprazole, olanzapine, quetiapine or risperidone, another antidepressant such as mianserin or mirtazapine. Duration of treatment. O use antidepressants for at least 6 to 9 months for first episode depression or 2 years for recurrent depression. O all patients should be informed about the withdrawal, discontinuation effects of antidepressants. Response to treatment. O there is a 55-70% response rate with antidepressants for acute depression. O if a person's depression has not responded to either biological or psychological interventions, consider combining antidepressants with cognitive behavioral therapy. Electroconvulsive therapy ECT is supported in severe and treatment-resistant depression. Key points that patients should know about antidepressants. Contrary to the common belief that antidepressants often take 2 to 4 weeks to start working, there is compelling evidence that antidepressants at effective doses produce partial improvements within the first 2 weeks of treatment. For example, reduced motor retardation and irritability in addition to initial improvements in mood and sleep. A single episode of depression should be treated for at least 6 to 9 months after remission. The risk of recurrence of depressive illness is high and increases with each episode. Those who have had multiple episodes of depression may require treatment for many years. Antidepressants are O effective, O not addictive, O not known to lose their efficacy over time, O not known to cause new long-term side effects. Medication needs to be continued at the treatment dose. If side effects are intolerable, it may be possible to find a more 56 suitable alternative. If patients decide to stop their medication, this must not be done suddenly, as it may lead to unpleasant discontinuation effects. The medication needs to be reduced slowly under the supervision of a doctor. Are antidepressants associated with an increased risk of suicide? According to the British Association of Pharmacology, BAP, guidelines 2015, antidepressant including SSRI treatment is not associated with an increased risk of completed suicide, and ecological studies find it is associated with decreased suicide rates. Antidepressant including SSRI treatment does not appear associated with a clinically significant increased risk of suicidal behavior in adults, although individual sensitivity cannot be ruled out. SSRIs are associated with a small 1% increase in non-fatal suicidal ideation behavior in adolescents. Younger adults with a benefit-risk ratio of 10. Tricyclic antidepressants TCA's indications. Additional features. Plasma levels can be measured. Amitriptyline, depression, nocturnal enuresis in children, neuropathic pain unlicensed, migraine prophylaxis, unlicensed, has an active metabolite, nortriptyline, nocturnal enuresis in children, neuropathic pain, depression, imipramine, nocturnal enuresis in children, has an, depression, active metabolite, disipramine, trimipramine, lafepramine, dothepin, dajulapin, has an safest TCA in overdose, clomipramine, depression, obsessive compulsive disorder, phobias, adjunctive treatment of cataplexy associated with narcolepsy, has an active metabolite, dismethiclomipramine, most potent 5-HT reuptake blocker of the TCAs, active metabolite, disipramine has an active metabolite, desmethyldajulepin, most toxic TCA in overdose. Note, type 1 metabolism converts tertiary to secondary amine S, for example amitriptyline, nortriptyline, imipramine, disipramine, clomipramine, desmethylclomipramine. Note, tertiary amine S are more potent 5-HT uptake blockers than secondary amine S. Secondary amine S are more potent noradrenaline reuptake blockers, selective serotonin reuptake inhibitors. SSRI indications. Additional features. Has an active metabolite, norfluoxetine. Has the longest half-life of the SSRIs, approximately 5 days. Has the strongest protein binding of the SSRIs, 95%. Rarely prescribed in Ireland. Half-life is shorter in males than females. Half-life is shorter in males than females. post-traumatic stress disorder. Note: discontinuation. Withdrawal symptoms are more common in SSRIs with shorter half-lives and inactive metabolites, for example paroxetine, sertraline, and fluvoxamine. The incidence of discontinuation symptoms are highest with paroxetine followed by fluoxetine, obsessive compulsive disorder, depression, anorexia nervosa or bulimia nervosa. Paroxetine, depression, obsessive compulsive disorder, panic disorder plus agoraphobia, social phobia, generalized anxiety disorder, post-traumatic stress disorder, has a short half-life, 10-20 hours, and therefore has a greater risk of discontinuation. Withdrawal symptoms compared to the other SSRIs. Note: SSRI discontinuation syndrome usually develops after 1 month of SSRI treatment. Within 2 to 5 days after SSRI discontinuation or dose reduction, dizziness, gait instability, nausea, fatigue, headache, insomnia, agitation, fluvoxamine, obsessive compulsive disorder, depression, citalopram, panic disorder plus agoraphobia, escitalopram, depression, obsessive compulsive disorder, panic disorder plus agoraphobia, social phobia, generalized anxiety disorder, sertraline, obsessive compulsive disorder, depression. 57.
Fluvoxamine, sertraline, citalopram and fluoxetine have a lower occurrence of withdrawal symptoms. Note: SSRIs can be used to treat premature ejaculation as they delay ejaculation. Note: avoid the combination of MAOI with SSRI or TCA due to the risk of developing the serotonin syndrome. Note: acutely, i.e. short-term administration, SSRIs block reuptake at the cell body leading to decreased firing of the neuron due to the action of serotonin on BND-HT autoreceptors. Note: chronically, i.e. long-term administration, SSRIs downregulate BND-HT autoreceptors, increasing the firing rate of the neuron. In the presence of reuptake, more serotonin is available to act postsynaptically. Comparison between tricyclic antidepressants and selective serotonin reuptake inhibitors. Factor: tricyclic antidepressants, selective serotonin reuptake. TCAs, inhibitors, SSRIs. Mechanism of action: inhibits the reuptake of serotonin and norepinephrine. This produces the antidepressant effect, blocks the cholinergic, histaminic and adrenergic receptor sites, inhibits the reuptake of serotonin. This produces the antidepressant effect. Note: BND-HT agonism produces the antidepressant, anxiolytic, anti-obsessional, antibulimic effect. Side effects: anticholinergic, antimuscarinic emina effects, dry mouth, blurred vision, drowsiness, constipation and urinary retention. Note: be cautious prescribing TCAs to people with closed-angle glaucoma and antihistaminic, HNA effects, sedation and weight gain, alpha-NA blockade effects, postural hypertension and sedation, cardiovascular effects. Through a combination of anticholinergic activity, direct myocardial depressant activity and an effect on the adrenergic neuron, TCAs can cause severe arrhythmias, hypertension and failure. The major side effects at therapeutic dosage include tachycardia, postural hypertension and slight prolongation of the intraventricular conduction time and QT interval. Note: TCAs can cause tachycardia, combination orthostatic congestive heart, due to their selectivity in inhibiting the reuptake of serotonin. There are fewer side effects associated with SSRIs than with TCAs: gastrointestinal effects, nausea and vomiting, central nervous system effects, headache, dizziness, agitation, insomnia and tremor, sexual dysfunction. SSRIs are more likely to cause sexual dysfunction than TCAs. SSRIs decrease libido and can cause anorgasmia. Note: BND-HT agonism produces agitation, akaphasia, anxiety, panic, insomnia and sexual dysfunction. Note: BND-HT agonism produces GI upset, diarrhea and headache. Less safe than SSRIs, lower than SSRIs, equal to SSRIs, higher than SSRIs, lower than SSRIs, safer than TCAs, higher than TCAs, equal to TCAs, lower than TCAs, higher than TCAs. Good effect: little no evidence of impact on chronic pain, using someone with cardiovascular disease or epilepsy. Tolerability. Efficacy for the treatment of depression, risk of interaction with alcohol and other medications, risk of developing the serotonin syndrome, impact on chronic pain, advantages of SSRIs over TCAs, less sedating, no anticholinergic side effects, lower cardiotoxicity, safer in overdose. Note: like TCAs, SSRIs reduce the seizure threshold and must be used with care in people with epilepsy. Penindoctor, risk of toxicity and lethality in overdose, more dangerous than SSRIs. Note: be cautious prescribing TCAs to people with suicidal ideation or a past history of multiple overdoses, less dangerous than TCAs. Amitriptyline has a variant chronic pain without depression.
Newer antidepressants. Venlafaxine. Reboxetine, trazodone, myanserin, mirtazapine, bupropion. Mechanism of action: serotonin noradrenaline reuptake inhibitor, SNRI, noradrenaline reuptake inhibitor, NARI, serotonin antagonist and reuptake inhibitor, SADI, tetracyclic antidepressant, TICA, noradrenergic and specific serotonergic antidepressant, NASA, noradrenergic and dopaminergic reuptake inhibitor, NDRI. Indications: main side effects: depression, generalized anxiety disorder, depression, nausea, dry mouth, constipation, dizziness, headache, insomnia, somnolence, sexual dysfunction, hypertension at higher doses, nausea, dry mouth, constipation, dizziness, headache, insomnia, sedation, priapism, sedation, rash, sedation, weight gain, nausea, dry mouth, dizziness, weight loss, agitation, reduced seizure threshold, duloxetine, serotonin noradrenaline reuptake inhibitor, SNRI, depression, generalized anxiety disorder, diabetic neuropathy, chronic pain, urinary stress incontinence, nausea, dry mouth, constipation, dizziness, headache, insomnia, somnolence, sexual dysfunction, hypertension, anxiety, depression, nicotine dependence. Agomelatine simultaneously acts as a MT1 and MT2 melatonergic receptors agonist and a 5-HT2C receptor antagonist. Note: agomelatine is the first melatonergic antidepressant. Note: agomelatine resynchronizes circadian rhythms that are disrupted in depressed patient. Depression, nausea, dizziness, headache, insomnia, somnolence, upper abdominal pain, excessive sweating, hyperhidrosis, increased LFTs. Note: agomelatine is contraindicated in people with hepatic impairment. Vortioxetine, multimodal activity, inhibits serotonin reuptake and modulates serotonin receptor activity. Depression, nausea, abnormal dreams, dizziness, diarrhea, constipation, vomiting. Pruritus, monoamine oxidase inhibitors. MAOIs are rarely prescribed nowadays and are mainly of historical interest. The four main MAOIs are isocarboxazid, phenelzine, tranylcypromine and silegiline. Silegiline is used for its anti-Parkinsonian properties rather than its antidepressant properties. MAOIs exist in two forms: irreversible and reversible inhibitors of monoamine oxidase, phenelzine. Isocarboxazid and tranylcypromine are irreversible inhibitors of monoamine oxidase. Omatolobamide is a reversible inhibitor inhibitor of monoamine oxidase. The potential for a hypertensive crisis caused by eating tyramine rich foods and interactions with certain medications, for example, sympathomimetics, levodopa, opioids, and other antidepressants, is greatly reduced with a reversible inhibitor compared to an irreversible inhibitor of monoamine oxidase. Sources of dietary tyramine include O cheese except cottage and cream cheese, O meat and yeast extracts, for example, Bovril, Marmite, OXO, and other fermented soybean extracts, O alcohol including low alcohol drinks, O hum game, O non-fresh fish, O non-fresh poultry, O offal, O avocado. 59. Page 57 of 284.
O bananas, beans, O broad bean pods, O caviar, O herring, pickled or smoked. Washout period to reduce the potential for developing the serotonin syndrome. OMAOIs should not be given 4 to 5 weeks after the discontinuation of SSRI or other serotonergic agents such as clomipramine, 5 weeks for fluoxetine, 2 weeks for paroxetine. No SSRIs or other serotonergic agents such as clomipramine should not be given 4 to 2 weeks after the discontinuation of an MAOI. MAOI type, indications, main side effects, major interactions. Phenelzine, irreversible MAOI, depression, postural hypotension, dizziness, drowsiness, anticholinergic effects, weight gain, nervousness, edema, hepatotoxicity, tyramine in food.
Hypertensive crisis, flushing, headache, hypertension, rarely cerebrovascular accident. Note, treatment of a hypertensive crisis.
A blockade with phentolamine or chlorpromazine, sympathomimetics, alcohol, antidepressants, opioids, levodopa, isocarboxazide, irreversible MAOI, tranylcypromine, irreversible MAOI, depression. Depression, as with phenelzine, as with phenelzine, as with phenelzine, as with phenelzine, meclobamide, reversible inhibition of monoamine oxidase A, REMA, depression, social phobia, sleep disturbances. Nausea, agitation, confusion. Tyramine interactions are rare and mild but possible if high doses used or if large quantities of tyramine are ingested. Antidepressant-induced hyponatremia. Hyponatremia, clinically defined as sodium levels of less than 135 mmol/ml, is a recognized side effect of all classes of antidepressants. Hyponatremia has a range of side effects including lethargy, confusion, convulsions, and coma. No antidepressant has been shown not to be associated with hyponatremia. It has been suggested that serotonergic agents are most likely to cause hyponatremia, e.g., SSRIs and SNRIs. The mechanism for hyponatremia is probably the syndrome of inappropriate secretion of antidiuretic hormone, SIADH. Risk factors for hyponatremia. O increase in age. O female gender. O a number of disease states predispose patients to hyponatremia, including renal failure, conditions which cause damage to the kidneys, hypertension, diabetes, pyelonephritis, heart failure, circulating volume depletion, hormonal imbalances, and malignancies. A number of medications can cause or exacerbate a patient's hyponatremia, including diuretics, desmopressin, antiepileptics, antipsychotics, antidepressants, anti-cancer drugs, most notably vincristine, and NSAIDs. As with most medications, the risk of hyponatremia with antidepressants is highest during the early stages of treatment. Management. O mild hyponatremia may be managed with fluid restriction. O if symptoms persist, the antidepressant should be discontinued. When restarting treatment, consider prescribing an antidepressant from a different class, e.g. noradrenergic agents or MAOI. Serotonin syndrome. A 3-year-old woman presented to the emergency department with confusion and agitation. She was found to exhibit rigidity, tremor, and lower limb hyperreflexia. Vital signs at presentation were as follows: 140/80 mmHg blood pressure, 105 beats mean pulse rate, 22 breaths mean respiratory rate, 38 peritory temperature, and 90% oxygen saturation. Her husband reported that the only medications that she had been taking were paroxetine and tramadol. There was no known history of alcohol or illicit substance misuse. Shercent attended her GH increase at her dose of paroxetine. Introduction. A potentially life-threatening condition caused by elevated serotonin concentrations in the body. The condition can occur in the context of the initiation or dose increase of a serotonergic agent, inadvertent interactions between serotonergic medications, overdose of serotonergic medications, or the recreational use of certain drugs. Specific agents that are associated with the serotonin syndrome include O antidepressants, e.g., SSRI, TCA, SNRI, SERI, MAOI, Exinda.
O mood stabilizers, for example lithium. O analgesics, for example tramadol, fentanyl, pethidine, pentazocine, buprenorphine, oxycodone, hydrocodone. O 5-HT1 agonists, for example triptans. O CNS stimulants, for example amphetamines, cocaine, methylphenidate, methamphetamine, DAT. O hallucinogens, for example MDMA, ecstasy, LSD. O other, for example Street John's wort, dietary supplements containing tryptophan. Symptoms, signs: psychiatric, neurological, agitation, confusion, coma, death, neuromuscular, ataxia, hyperreflexia usually of the lower rather than the upper limbs, myoclonus, rigidity, autonomic, gastrointestinal upset, nausea, diarrhea, hypertension, hypothermia, mydriasis, tachycardia. Comparison between serotonin syndrome and neuroleptic malignant syndrome. Tremors, neuroleptic malignant syndrome, antipsychotic medication, dopamine antagonism, days 2 weeks 5-14 days, severe lead pipe bradykinesia, rare, common feature, associated agent, mechanism, onset of symptoms, resolution of symptoms, muscle rigidity, activity, myoclonus and seizures, rhabdomyolysis, elevated transaminases, management, serotonin syndrome, serotonergic agent, serotonin excess, minutes to hours less than 24 hours less, severe, hyperkinesia, common, rare, severe symptoms, requires immediate transfer to the emergency department for supportive treatment and acute management. If overdose. Consider gastric lavage and or activated charcoal. Biological. Or discontinue any serotonergic agents or benzodiazepines may be helpful to relieve muscular symptoms or serotonin receptor antagonists. For example, cyproheptadine or beta blockers. Propranolol and pindolol may be useful in reversing some of the neuromuscular and autonomic complications and are especially useful if tachycardia and or hypertension are present. Course and prognosis. Most cases resolve without sequelae within 24-36 hours with adequate supportive measures. Restart serotonergic agents slowly and at low doses and consider using a serotonergic agent from a different class. 2. Psychological management of depression. Psychoeducation. Supportive therapy. Cognitive behavioral therapy. Psychoanalytical psychotherapy. Interpersonal psychotherapy. Family and couples therapy. Mindfulness. Note: see Chapter 20 on psychotherapy for a description on each of the above forms of psychological management. 3. Social management of depression. See Chapter 8. Note: the biological, psychological and social management strategies given in Chapter 8 are general options without considering any particular patient. However, it is important to tailor the management strategies to each individual patient by selecting those options which are appropriate for that case. 61. Notes Chapter 11, 62. Chapter 12, Management of Acute Mania and Bipolar Affective Disorder. 63. Chapter 12, Management of Acute Mania and Bipolar Affective Disorder. 1. Biological management. 2. Psychological management. 3. Social management. 1. Biological management. Reference: NICE Guideline, CG 185. Bipolar disorder. The assessment and management of bipolar disorder in adults, children and young people in primary and secondary care. Published September 2014, last updated April 2018. A management of an acute manic or hypomanic episode. The treatment of an acute manic episode depends on the severity of symptoms and whether the patient is currently taking anti-manic medication. If a person develops mania or hypomania and is taking an antidepressant, or consider stopping the antidepressant and or offer an antipsychotic, regardless of whether the antidepressant is stopped. If a person develops mania or hypomania and is not taking an antipsychotic or mood stabilizer, or offer haloperidol, olanzapine, quetiapine or risperidone, taking into account any advance statements, the person's preference and clinical context including physical comorbidity, previous response to treatment and side effects, or if the first antipsychotic is poorly tolerated at any dose including rapid weight gain, or ineffective at the maximum licensed dose, offer an alternative antipsychotic, taking into account any advance statements, the person's preference, and clinical context including physical comorbidity, previous response to treatment and side effects, or if an alternative antipsychotic is not sufficiently effective at the maximum licensed dose, consider adding lithium. If adding lithium is ineffective, or if lithium is not suitable, for example, because the person does not agree to routine blood monitoring, consider adding valproate instead. If a person develops mania or hypomania and is taking an antidepressant in combination with a mood stabilizer, or consider stopping the antidepressant, or if the person is already taking lithium, check plasma lithium levels to optimize treatment. Consider adding haloperidol, olanzapine, quetiapine or risperidone, depending on the person's preference and previous response to treatment, or if the person is already taking valproate or another mood stabilizer as prophylactic treatment. Consider increasing the dose up to the maximum level in the BNF if necessary, depending on clinical response. If there is no improvement, consider adding haloperidol, olanzapine, quetiapine or risperidone, depending on the person's preference and previous response to treatment, or do not offer lamotrigine to treat mania. Duration of treatment, or within 4 weeks of resolution of symptoms. Discuss with the person and their carers if appropriate, whether to continue treatment for mania or start long-term treatment. Explain the potential benefits of long-term treatment and the risks, including side effects of medication used for long-term treatment, or if the person decides to continue treatment for mania, offer it for a further 3-6 months, and then review. 64. Treatment algorithm for acute mania or hypomania. Reference: Maudsley Prescribing Guidelines in Psychiatry, 13th edition, 2018. B. Management of Bipolar Affective Disorder. Reference: NICE Guideline, CG 185. Bipolar disorder. The assessment and management of bipolar disorder in adults, children and young people in primary and secondary care. Published September 2014, last updated April 2018. Management of an acute manic episode. O management is the same as described above in A. Management of bipolar depression. O if a person develops moderate or severe bipolar depression and is not taking medication to treat their bipolar disorder, offer fluoxetine combined with olanzapine, or quetiapine on its own, depending on the person's preference and previous response to treatment. If the person prefers, consider either olanzapine without fluoxetine or lamotrigine on its own. If there is no response to fluoxetine combined with olanzapine, or quetiapine, consider lamotrigine on its own. Or if a person develops moderate or severe bipolar depression and is already taking lithium, check their plasma lithium level. If it is inadequate, increase the dose of lithium. If it is at maximum level, add either fluoxetine combined with olanzapine olanzapine or adquisiapine, depending on the person's preference in previous response to treatment. If the person prefers, consider adding olanzapine without fluoxetine or lamotrigine to lithium. If there is no response to adding fluoxetine combined with olanzapine, or adding quetiapine, stop the additional treatment and consider adding lamotrigine to lithium. Or if a person develops moderate or severe bipolar depression and is already taking valproate, consider increasing the dose within the therapeutic range. If the maximum tolerated dose, or the top of the therapeutic range, has been reached and there is a limited response to valproate, add fluoxetine combined with olanzapine or add quetiapine, depending on the person's preference and previous response to treatment. If the person prefers, consider adding olanzapine without fluoxetine or lamotrigine to valproate. If there is no response to adding fluoxetine combined with olanzapine, or adding quetiapine, stop the additional treatment and consider adding lamotrigine to valproate. Or take into account toxicity in overdose when prescribing psychotropic medication during periods of high suicide risk. Assess the need to limit the quantity of medication supplied to reduce the risk to life if the person overdoses. Or duration of treatment, within 4 weeks of resolution of symptoms. Discuss with the person and their carers if appropriate, whether to continue psychological or pharmacological treatment for bipolar depression or start long-term treatment. Explain 65. The potential benefits of long-term treatment and the risks, including side effects of medication used for long-term treatment if the person decides to continue psychological or pharmacological treatment for bipolar depression. Offer it for a further 3-6 months, and then review. 2. Psychological management of bipolar depression and bipolar affective disorder. Reference: NICE Guideline, CG 185. Bipolar disorder. The assessment and management of bipolar disorder in adults, children and young people in primary and secondary care. Published September 2014, last updated April 2018. Bipolar depression. Offer a psychological intervention that has been developed specifically for bipolar disorder and has a published evidence-based manual describing how it should be delivered, or a high-intensity psychological intervention, cognitive behavioral therapy, interpersonal therapy or behavioral couples therapy. Or discuss with the person the possible benefits and risks of psychological interventions and their preference. Monitor mood for signs of mania or hypomania or deterioration of the depressive symptoms. Management of bipolar disorder in the longer term. Offer a family intervention to people with bipolar disorder who are living, or in close contact with their family. Or offer a structured psychological intervention, individual, group or family, which has been designed for bipolar disorder and has a published evidence-based manual describing how it should be delivered, to prevent relapse or for people who have some persisting symptoms between episodes of mania or bipolar depression. Or individual and group psychological interventions for bipolar disorder to prevent relapse should provide information about bipolar disorder. Consider the impact of thoughts and behavior on moods and relapse. Include self-monitoring of mood, thoughts and behavior. Address relapse risk, distress and how to improve functioning. Develop plans for relapse management and staying well. Consider problem solving to address communication patterns and managing functional difficulties. In addition, individual programs should be tailored to the person's needs based on an individualized assessment and psychological formulation, and group programs should include discussion of the information provided with a focus on its relevance for the participants. Note: help to teach patients to recognize the warning signs of relapse so that they can seek early treatment. For example, reduced sleep, increased activity levels, elevated or irritable mood, and grandiose or otherwise unrealistic plans. Since people commonly lose insight early in the course of the illness, it is vital to involve the family in recognizing a person's relapse signature and seeking early treatment. Note: it is beneficial to educate patients about the common precipitants for mania, for example, stressful life events, substance abuse, cessation of lithium, and disruption of the sleep-wake cycle. See Chapter 8. 3. Social management. Note: the biological, psychological, and social management strategies given in Chapter 8 are general options without considering any particular patient. However, it is important to tailor the management strategies to each individual patient by selecting those options which are appropriate for that case. 66. Notes: Chapter 12, 67. Chapter 13, Mood Stabilizers, 68. 1. Lithium. 2. Valproate. 3. Carbamazepine. 4. Lamotrigine. Indications. 1. Lithium. Chapter 13. Mood stabilizers. Treatment of mild to moderate mania. The use of lithium for mania is limited by the fact that it usually takes at least 1 week to achieve a response and that the co-administration of antipsychotics may increase the risk of neurological side effects. Prophylaxis of bipolar affective disorder. Lithium is more effective at preventing manic than depressive relapses. Prophylaxis of recurrent depression. In people who have not responded to standard antidepressants, lithium can be added for antidepressant augmentation. Treatment of aggressive behavior, treatment of self-mutilating behavior, prevention and treatment of steroid-induced psychosis, lithium and suicide. Lithium decreases suicidal behavior in people with unipolar or bipolar disorder. Duration of treatment. Because of the risk of relapse following discontinuation, the need for prolonged treatment at least 3 years should be discussed with patients. Monitoring prior to starting lithium. Bloods, RFTs, TFTs, calcium level, ECG, weight. Exclude pregnancy after starting or changing the dose of lithium. Serum lithium should be measured after 5-7 days. The lithium dose should should then be adjusted to achieve a serum lithium concentration of between 0.5-0.8 mol. Note: lithium has a narrow therapeutic index window, or blood should ideally be taken 12 hours after the last dose was administered. Note: lithium is usually taken at night time during treatment. Check serum lithium level every 3 months. Check RFTs, TFTs and calcium level every 6 months. Monitor weight. Advise patients to seek attention if symptoms of hypothyroidism develop. For example, lethargy and feeling cold. If lithium is to be discontinued, the dose should be reduced gradually over a period of a few weeks. Patients should be warned of possible relapse if lithium is discontinued abruptly. Lithium formulations: lithium carbonate, lithium in the form of tablets, lithium citrate, lithium in the form of liquid. Note: both lithium carbonate and citrate have the same indications as listed above. Use in women of childbearing age. Any female of childbearing potential should receive appropriate advice about contraception. Lithium is a human teratogen. Women should be advised to use a reliable form of contraception. Risks to consider when lithium is prescribed during pregnancy. Fetal heart defects. Risk raised from 8 in 1000 to around 60 in 1000. Epstein's anomaly. Risk raised from 1 in 20,000 to 10 in 20,000. Floppy baby syndrome. Potential thyroid abnormalities. For example, goiter and nephrogenic diabetes insipidus. Increased associated miscarriage risk with lithium treatment during pregnancy. Note: Epstein's anomaly is a congenital condition which occurs due to a defect in the tricuspid valve in which the septal and posterior leaflets are downwardly displaced into the right ventricle. The anterior leaflet is malformed and abnormally attached to the right ventricle free wall. Blood leaks backward from the right ventricle to the right atrium, resulting in an enlargement of the right atrium and the arterialization of the right ventricle, leading to congestive heart failure. Back up of blood flow that results in a fluid build-up in the lungs and insufficient blood flow to the body. Blue baby syndrome. Note: the period of highest risk for organ malformation is the first trimester of pregnancy. 69. Reference: NICE Clinical Guidance CG 192, Antenatal and Postnatal Mental Health, Clinical Management and Service Guidance. Published December 2014. Last updated April 2018. Considerations for women of childbearing potential. Discuss with all women of childbearing potential who have a new, existing or past mental health problem. The use of contraception and any plans for a pregnancy. How pregnancy and childbirth might affect a mental health problem, including the risk of relapse. How a mental health problem and its treatment might affect the woman, the fetus and baby. How a mental health problem and its treatment might affect parenting. Do not offer lithium to women who are planning a pregnancy or pregnant, unless antipsychotic medication has not been effective. If antipsychotic medication has not been effective and lithium is offered to a woman who is planning a pregnancy or pregnant, ensure the woman knows that there is a risk of fetal heart malformations when lithium is taken in the first trimester, but the size of the risk is uncertain. The woman knows that lithium levels may be high in breast milk with a risk of toxicity for the baby. Lithium levels are monitored more frequently throughout pregnancy and the postnatal period. If a woman taking lithium becomes pregnant, consider stopping the drug gradually over 4 weeks if she is well. Explain to her that, stopping medication may not remove the risk of fetal heart malformations. There is a risk of relapse, particularly in the postnatal period. If she has bipolar disorder. If a woman taking lithium becomes pregnant and is not well or is at high risk of relapse, consider switching gradually to an antipsychotic or stopping lithium and restarting it in the second trimester. If the woman is not planning to breastfeed and her symptoms have responded better to lithium than to other drugs in the past, or continuing with lithium if she is at high risk of relapse and an antipsychotic is unlikely to be effective. If a woman continues taking lithium during pregnancy, check plasma lithium levels every 4 weeks, then weekly from the 36th week. Adjust the dose to keep plasma lithium levels in the woman's therapeutic range. Ensure the woman maintains an adequate fluid balance. Ensure the woman gives birth in hospital. Ensure monitoring by the obstetric team when labor starts, including checking plasma lithium levels and fluid balance. Because of the risk of dehydration and lithium toxicity, stop lithium during labor and check plasma lithium levels 12 hours after her last dose. Note: breastfeeding is not advised as lithium is excreted in breast milk. However, if a woman strongly wishes to breastfeed, it is best to advise staying on lithium rather than coming off medication and suffering a relapse. Refer to the Dutch Emson case in which Dr. Dutch Emson, a psychiatrist suffering from bipolar affective disorder, ended her life and that of her 3-month-old daughter Freya on 9 October 2000. Side effects: early gastrointestinal effects, vomiting, nausea, diarrhea, polyuria and polydipsia, fine tremor, especially on voluntary movement. Propranolol may be useful for lithium-induced dryness of mouth, slight thirst fatigue, drowsiness muscle weakness metallic taste in the mouth. Disulfiram and zopiclone can also produce the same effect. Tremor, at any time toxicity. Exacerbation of existing side effects, gastrointestinal disturbance, nausea, vomiting, diarrhea, course, tremor, ataxia, incoordination, slurred speech, confusion, disorientation, convulsion, coma, death. Signs begin to appear with lithium blood level greater than 1.3 mol. Lithium has a narrow therapeutic index, hence the need for regular monitoring. Anything affecting fluid balance can cause toxicity in previously stable individuals. Dehydration, excessive sweating, vomiting and diarrhea, diuretics, for example thiazides. Treatment of lithium toxicity. Admission may be required for dehydration and administration of anticonvulsants depending on severity. Osmotic diuresis or forced alkaline diuresis. Hemodialysis may be needed where serum levels greater than 3 mol. Coma supervenes, or if there is no response to supportive measures over 24 hours. Longer-term O nephrogenic diabetes insipidus O nephropathy O hypothyroidism risk for females males. In middle-aged women, the risk may be up to 20%. Note, there is no need to stop lithium if hypothyroidism develops. It is often reversible, but may recur on restarting lithium O hyperparathyroidism and hypercalcemia, O edema. 70. O weight gain not accounted for by water retention. Note, one theory for the weight gain is that increased thirst leads people to drink high-calorie fluids. Other possibilities include endocrinological mechanisms leading to an increase in fat storage and lithium-induced hypothyroidism which slows metabolism causing less burning of dietary calories in general. Note, weight gain or edema should not be treated with diuretics since thiazides and loop diuretics reduce lithium excretion and can therefore cause lithium toxicity, O cardiotoxicity, arrhythmias, cardiac T, wave flattening on ECG or reduced memory short-term. Side effect of lithium within the therapeutic range. Fine rapid intentional tremor, lithium toxicity, causing of the tremor. Note, lithium is not metabolized by the liver and therefore may be the best choice of treatment in people with bipolar affective disorder with hepatic impairment. Note, single daily dosing of lithium may reduce the risk of polyuria and renal impairment. Note, lithium is excreted unchanged by the kidney. Caution in people with renal disease. Use lower doses of lithium in renal impairment. Interaction with other medications. Due to lithium's narrow therapeutic window, interactions with other medications can precipitate lithium toxicity. For example, O-angiotensin converting enzyme, ACE. Inhibitors O anti-inflammatory drugs NSAIDs O diuretics especially thiazide diuretics. Note, the above medications can reduce the renal clearance of lithium therefore increasing the concentration of lithium. Other factors which may increase the concentration of lithium are a low-salt diet, diarrhea, vomiting and excessive sweating. Indications, treatment and prophylaxis of mania, treatment and prophylaxis of depression, treatment of rapid cyclic bipolar disorder, monitoring, prior to starting valproate, O bloods, FBC, LFTs, weight, exclude pregnancy during treatment, O check serum valproate level every 3 months O check FBC and LFTs every 6 months O monitor weight. Valproate formulations. 2. Valproate, sodium valproate, valproate in the form of tablets or liquid, valproic acid, valproate in the form of tablets, semi-sodium valproate, valproate in the form of tablets, use in women of childbearing age. Reference, NICE Clinical Guidance CG 192, Antenatal and Postnatal Mental Health, Clinical Management and Service Guidance, published December 2014 last updated April 2018, do not offer valproate for acute or long-term treatment of a mental health problem in women who are planning a pregnancy, pregnant or considering breastfeeding. If a woman is already taking valproate and is planning a pregnancy, advise her to gradually stop the drug because of the risk of fetal malformations and adverse neurodevelopment outcomes after any exposure in pregnancy. If a woman is already taking valproate and becomes pregnant, stop the drug because of the risk of fetal malformations and adverse neurodevelopmental outcomes. Note, fetal valproate syndrome consists of O facial anomalies, flat nasal bridge, epic and thick folds, small nose with antiverted nostrils, long, set ears, hypertelorism O congenital heart disease O neural tube defects O skeletal anomalies, radial aplasia and thumb abnormalities O spinal abnormalities open spinal defects, side effects, gastrointestinal effects, gastric irritation, nausea, diarrhea, drowsiness, weight gain, upper lip, small mouth, low. 71. Hyperammonemia, thrombocytopenia agranulocytosis anemia, transient hair loss alopecia, regrowth may be curly, hepatic and pancreatic toxicity dysfunction, rare. Indications, 3. Carbamazepine, treatment and prophylaxis of depression, treatment and prophylaxis of mania not as a first-line treatment, prophylaxis of bipolar affective disorder in people unresponsive to lithium, treatment of trigeminal neuralgia, monitoring, prior to starting carbamazepine, bloods, FBC, RFTs, LFTs, weight, exclude pregnancy, during treatment, O check serum carbamazepine level every 3 months O check FBC, RFTs and LFTs every 6 months O monitor weight, carbamazepine formulations, liquid, tablets, immediate release tablets or controlled release tablets, use in women of childbearing age. Reference, NICE Clinical Guidance CG 192, Antenatal and Postnatal Mental Health, Clinical Management and Service Guidance, published December 2014 last updated April 2018, do not offer carbamazepine to treat a mental health problem in women who are planning a pregnancy, pregnant or considering breastfeeding. If a woman is already taking carbamazepine and is planning a pregnancy or becomes pregnant, discuss with the woman the possibility of stopping the drug because of the risk of adverse drug interactions and fetal malformations, side effects, gastrointestinal effects, nausea and vomiting, diplopia, headaches, dizziness, drowsiness, ataxia, agranulocytosis, 1 in 20,000 people. Note, avoid using clozapine and carbamazepine together as both can cause agranulocytosis. The risk for agranulocytosis is increased if these agents are used together. Thrombocytopenia, aplastic anemia, 1 in 20,000 people. Generalized erythematosus rash 3% of people. Stevens-Johnson syndrome X following conjunctivative rash, is a rare but potentially fatal side effect. 4. Lamotrigine indications. Treatment of depressive episodes in bipolar affective disorder. Prophylaxis of bipolar affective disorder. Monitoring. Prior to starting lamotrigine. Bloods, FBC, LFTs. Exclude pregnancy. During treatment. Bloods, FBC, LFTs. Use in women of childbearing age. Reference. NICE Clinical Guidance CG 192. Antenatal and postnatal mental health. Clinical management and service guidance. Published December 2014. Last updated April 2018. If a woman is taking lamotrigine during pregnancy, check lamotrigine levels frequently during pregnancy and into the postnatal period because they vary substantially at these times. Side effects. Gastrointestinal effects. Nausea and vomiting. Diplopia. 72. Headaches, dizziness, rash, serious skin reactions including Stevens-Johnson syndrome and toxic epidermal necrolysis rarely with fatalities have developed especially in children. Most rashes occur in the first 8 weeks. Rash is more common in people with a history of allergy or rash from other anti-epileptic mood stabilizer agents. Consider withdrawal if rash develops. 73. Notes Chapter 13, 74. Chapter 14, Schizophrenia, Schizotypal and Delusional Disorders, 75. Chapter 14, Schizophrenia, Schizotypal and Delusional Disorders. Introduction. Schizophrenia is a major psychiatric disorder, or cluster of disorders, characterized by psychotic symptoms that alter a person's perception, thoughts, affect and behavior. Each person with the disorder will have a unique combination of symptoms and experiences. Typically there is a prodromal period often characterized by some deterioration in personal functioning. This includes memory and concentration problems, unusual behavior and ideas, disturbed communication and affect, social withdrawal, apathy and reduced interest in daily activities. These are sometimes called negative symptoms. The prodromal period is usually followed by an acute episode marked by hallucinations, delusions, and behavioral disturbances. These are sometimes called positive symptoms and are usually accompanied by agitation and distress, following resolution of the acute episode, usually after biological, psychological and other interventions. Symptoms diminish and often disappear for many people, although sometimes a number of negative symptoms may remain. This phase, which can last for many years, may be interrupted by recurrent acute episodes, which may need additional intervention. A significant number of people continue to experience long-term impairments and as a result, schizophrenia can have a considerable effect on people's personal, social and occupational lives. The disabilities experienced by people with schizophrenia are not solely the result of recurrent episodes or continuing symptoms. Unpleasant side effects of treatment, social adversity and isolation, poverty and homelessness also play a part. ICD-10 classification. 1. Schizophrenia, A. Paranoid schizophrenia, B. Hebephrenic schizophrenia, C. Catatonic schizophrenia, D. Undifferentiated schizophrenia, E. Post-schizophrenic depression, F. Residual schizophrenia, G. Simple schizophrenia. 2. Schizotypal disorder. 3. Persistent delusional disorders, A. Delusional disorder, B. Other persistent delusional disorders. 4. Acute and transient psychotic disorders, A. Acute polymorphic psychotic disorder without symptoms of schizophrenia, B. Acute polymorphic psychotic disorder with symptoms of schizophrenia, C. Acute schizophrenia-like psychotic disorder, D. Other acute predominantly delusional psychotic disorder. 5. Induced delusional disorder. 6. Schizoaffective disorders, A. Schizoaffective disorder, manic type, B. Schizoaffective disorder, depressive type, C. Schizoaffective disorder, mixed type. ICD-10 criteria. A minimum of one of the symptoms listed under 1 below, or at least 2 of the symptoms listed under 2, should be present. 1. Schizophrenia. For most of the time during a period of 1 month or more, conditions meeting such symptomatic requirements but of duration less than 1 month, whether treated or not, should be diagnosed as acute schizophrenic, like psychotic disorder, and reclassified as schizophrenia if the symptoms persist for longer periods. 1. At least one of the following must be present: A. Thought insertion, withdrawal, echo or broadcasting, B. Delusions of control, influence or passivity, clearly referred to body or limb movements or specific thoughts, actions, or sensations, delusional perception, hallucinatory voices giving a running commentary on the patient's behavior, or discussing the patient among themselves, or other types of voices coming from some part of the body. C. Persistent delusions of other kinds that are culturally inappropriate and completely impossible, such as religious or political identity, or superhuman powers and abilities, for example being able to control the weather, or being in communication with beings from another world. 2. Or at least 2 of the following: A. Persistent hallucinations in any modality, when accompanied either by fleeting or half-formed delusions without clear affective content, or by persistent overvalued ideas, or when occurring every day for weeks or months on end. B. Breaks in the train of thought, resulting in incoherent or irrelevant speech, or neologisms, that is the use of words that only 76 have meaning to the person who uses them. C. Catatonic behavior such as excitement, posturing or waxy flexibility, negativism, mutism and stupor. D. Negative symptoms, such as marked apathy, paucity of speech and blunting or incongruity of emotional response, usually resulting in social withdrawal and lowering of social performance. Subtypes A. Paranoid schizophrenia. Paranoid schizophrenia scenario. A 28-year-old man has been experiencing third-person auditory hallucinations for the past 6 months and believes that the FBI has formulated a plan to destroy him. Features of the condition. O. The commonest type of schizophrenia. O. Prominent delusions and/or auditory hallucinations. O. Better prognosis than hebephrenic and catatonic schizophrenia. Onset tends to be earlier in hebephrenic and catatonic schizophrenia. B. Hebephrenic schizophrenia. Hebephrenic schizophrenia scenario. A 20-year-old man has a 4-month history of disorganized speech, flattened affect and social withdrawal. He describes hearing multiple voices throughout much of the day. Features of the condition. O. Prominent disorganization of speech and behavior. Inappropriate flat affect. O. Negative symptoms, particularly flattening of affect and loss of volition, are prominent. O. Much rarer but worse prognosis than paranoid schizophrenia. Earlier onset than paranoid schizophrenia. Onset between 15-25 years. Rapid development of negative symptoms. C. Catatonic schizophrenia. Catatonic schizophrenia scenario. A 26-year-old man has a history of adopting bizarre postures. Features of the condition. O. Prominent psychomotor disturbances. O. Episodes of violent excitement may be a striking feature of the condition. O. Developed countries. Now rarely seen in developed countries. O. Dominated by stupor. Marked decrease in reactivity to the environment and in spontaneous movements. Excitement. Purposeless motor activity. Not influenced by external stimuli. Posturing. Voluntary assumption and maintenance of inappropriate or bizarre postures. Waxy flexibility. Maintenance of limbs and body in externally imposed positions. Negativism. An apparently motiveless resistance to all instructions or attempts to be moved, or movement in the opposite direction. Rigidity. Maintenance of a rigid posture against efforts to be moved. Other symptoms such as command automatism, automatic compliance with instructions and perseveration of words and phrases. The undifferentiated schizophrenia. Undifferentiated schizophrenia scenario. A 30-year-old man has a history of believing that the FBI have formulated a plan to destroy him. Disorganized speech and assuming unusual postures. Features of the condition. O. Psychotic conditions meeting the general diagnostic criteria for schizophrenia but not conforming to any of the subtypes, or exhibiting the features of more than one of them without a clear predominance of a particular set of diagnostic characteristics. E. Post-schizophrenic depression. Post-schizophrenic depression scenario. A 30-year-old man who was discharged from hospital following the treatment of a relapse of schizophrenia, presented with a reduced mood associated with disturbed sleep, appetite and energy. He also reported third-person auditory hallucinations which last for only a few seconds, approximately once per week. Features of the condition. O. A depressive episode which may be prolonged, arising in the aftermath of a schizophrenic illness. O. Some symptoms of schizophrenia must still be present but no longer dominate the clinical picture. F. Residual schizophrenia. Residual schizophrenia scenario. A 36-year-old man has a history of third-person auditory hallucinations and delusions that the FBI want to harm him. These symptoms however have reduced over the past year. He now presents with social withdrawal, affective blunting and impoverished speech. Features of the condition. O. Clear progression from an early stage with positive symptoms of schizophrenia to predominant negative symptoms. O. A period of at least 1 year during which the intensity and frequency of positive symptoms have been minimal or substantially reduced, and negative symptoms have been present. 77. G. Simple schizophrenia. Simple schizophrenia scenario. A 34-year-old man presented with social withdrawal, affective blunting and impoverished speech. He has no past history of positive symptoms. Features of the condition. O. Negative symptoms. O. No prior positive symptoms. Schneider's first-rank symptoms. Symptoms which, if present, are suggestive of schizophrenia. However, first-rank symptoms are found in both schizophrenia and other psychotic disorders. Furthermore, not all patients with schizophrenia have first-rank symptoms. They are therefore not specific or diagnostic for schizophrenia. The ICD-10 criteria for schizophrenia are used for the diagnosis of schizophrenia. The first-rank symptoms of schizophrenia include O. Auditory hallucinations. Hearing thoughts spoken aloud. Thought echo. Echo de lapency. The patient hears the echo of his thoughts in the form of a voice after he has made the thought. Gedanken lautwerden. The patient hears the echo of his thoughts in the form of a voice at the same time that he made the thought. Third-person auditory hallucinations. Hallucinations in the form of a running commentary. O. Delusions of passivity. Thought insertion. Thought withdrawal. Thought broadcasting. Note: thought block is not the same as thought withdrawal. Feelings or actions experienced as made or influenced by external agents. O. Somatic passivity, not somatic hallucinations. Somatic hallucinations are not a first-rank symptom. The patient has the feeling that he is a passive recipient of somatic or bodily sensations from an external agent. O. Delusional perception. A delusional perception is a delusional interpretation of a normal stimulus. For example, when I saw the traffic lights turn red, I knew that the dog I was walking was an alien in disguise. Or when I saw the cupboard door was slightly open, I knew that I was the King of England. The term delusional perception is misleading in that the perceptions are not abnormal. It is the meaning attached to the normal perception that is delusional. Note: first-rank symptoms are of no predictive prognostic value and are not heritable. Second-rank symptoms. Second-person auditory hallucinations. Secondary delusion. A false belief which arises from some preceding morbid experience, for example a prevailing mood, an existing delusion or a hallucination. Visual, tactile, olfactory and gustatory hallucinations. Perplexity. Emotional blunting. Note: second-rank symptoms are of less diagnostic significance than first-rank symptoms. Positive and negative symptoms. Positive symptoms. O. Positive symptoms are those that appear to reflect an excess excess or distortion of normal functions. O positive symptoms include delusions, hallucinations, formal thought disorder, that is disturbance of thought, for example loosening of associations. Common negative symptoms. O negative symptoms are those that appear to reflect a reduction or loss of normal functions. They often persist in the lives of people with schizophrenia during periods of low or absent positive symptoms. O negative symptoms include affective blunting, alogia, impoverished speech, avolition, lack of desire, drive, or motivation to pursue meaningful goals, apathy, a state of indifference or the lack or suppression of emotions such as concern, excitement, motivation and passion, anhedonia, an inability to experience pleasure from normally pleasurable life events such as eating, exercise, and social or sexual interaction, asociality, a lack of interest in relationships, social contact, attention disturbance. 78. Type 1 and Type 2 schizophrenia. Prof. Tim Crow hypothesized two classifications of schizophrenia known as Type 1 and Type 2. This terminology is no longer in common usage. Type of illness in which it is most commonly seen. Type of symptoms: prior level of premorbid functioning, underlying abnormality, neurological signs, cognition, response to antipsychotics, prognosis. Type 1 schizophrenia, acute schizophrenia, positive symptoms. Type 2 schizophrenia, chronic schizophrenia, negative symptoms. History of poor social and educational functioning prior to the appearance of symptoms, that is poor premorbid functioning, believed to be due to structural brain abnormalities. Functioned well before the appearance of symptoms, that is good premorbid functioning, believed to be due to problems in dopamine neurotransmission. Absent, not impaired. Good. Note: changes are therefore noticeable on a CT scan, unlike with Type 1 schizophrenia present impaired. Poor. Note: the commonest symptom of acute schizophrenia is loss of insight. Dopamine abnormalities in schizophrenia. Increased dopamine release in the mesolimbic striatum during illness exacerbations. O positively correlated with positive symptoms. O correlated with good treatment response to antipsychotic medication. Decreased dopamine in the mesocortical system. O associated with deficits in cognitive function, working memory. Note: dopamine dysregulation is not thought to be a primary abnormality in schizophrenia. The dopamine dysregulation is thought to be secondary to a more proximal abnormality, for example in GABA or glutamate systems. Rating scales. For item positive symptom rating scale and brief negative symptom assessment. Scale for the assessment of negative positive symptoms: SANS, SAPS. O observer rated scales measuring the severity of positive and negative symptoms. Positive and negative syndrome scale PANSS. O observer rated scale measuring the severity of positive and negative symptoms. Differential diagnosis of negative symptoms. Depression. O distinguished from negative symptoms by careful evaluation of the mood, thoughts, negative presence, absence of biological symptoms of depression. Effects of neuroleptic medication. O Parkinsonian side effects of the dopamine receptor blocking antipsychotics can mimic some. O loss of emotional reactivity, apathy and decreased speech are part of the akinetic picture. O distinguish from negative symptoms by looking for other features of Parkinsonism and considering any recent changes in medication. Environmental under stimulation. O a lack of stimulation and social interaction and or authoritarian routines allowing minimal individual initiative produces a lack of spontaneity, loss of emotional reactivity and drive. Physical illness. O endocrine disorders, for example hypothyroidism, cerebrovascular disease, some malignancies. O Alzheimer's disease. O all of the above illnesses can produce symptoms which are difficult to distinguish in their early stages from negative symptoms. Distinction from negative symptoms is made by careful history, physical examination and laboratory investigations. Substance misuse. O excess use of cannabis, withdrawal from amphetamines and the use of other drugs such as opiates can cause symptoms, including apathy, social withdrawal and impaired attention and concentration, which may mimic negative symptoms. O in addition, heavy long-term use of some drugs such as alcohol can cause organic impairment which results in changes in affect and many of the features of a negative symptom picture. O it is therefore necessary to take a history of alcohol and drug use and be alert to the physical and mental state, manifestations of such abuse. Schizoid and schizotypal personality traits disorders. O schizoid individuals have defects in their abilities to form social relationships and often seem aloof or withdrawn. Cognitions, suicidal risk and negative symptoms. 79. O schizotypal individuals may display social isolation, odd speech, inappropriate affect as well as other features also seen in negative symptoms. O a full history and collateral is necessary to determine if the features have been present from childhood adolescence when personality traits disorders arise. Autism and Asperger's syndrome. O these conditions have significant difficulties with social interaction. O distinguished from negative symptoms by the absence of restricted and repetitive patterns of behavior and interests which are a feature of autism and Asperger's syndrome. Blula, 1911 described the 4 A's symptoms he considered were characteristic of schizophrenia: ambivalence, simultaneous, contradictory thinking, autism, preoccupation with internal stimuli, inappropriate affect, external manifestations of mood, loosening of associations, illogical or fragmented thought processes. Epidemiology of schizophrenia, incidence. The number of new cases of schizophrenia diagnosed each year, 15-20 per 1 lakh per. Prevalence estimated population of people who are living with schizophrenia at any given time. Mean age at onset, males equals 22 years, females equals 26 years.
Gender, males, females. Inna, Pende, Enna, Note, Schizophrenia was previously thought to be equally common in males and females. Etiology of schizophrenia, Yearmiven, Pendeos and Atisa. Biological factors or genetics. A wealth of evidence supports a strong genetic contribution. Multiple genes of small effect. The heritability of schizophrenia is although Atisa. Relationship to person with schizophrenia. No relative affected. First cousins, uncles, aunts, plin 2%, nephews, nieces, plin 4%, grandchildren, plin 5%, parent, plin 6%, siblings, plin 10%. Risk of developing schizophrenia, plin 1%, plin 2%. Children of one affected parent, children of two affected parents, fraternal twin, identical twin, plin 13%, plin 46%, plin 17%, plin 48%. Susceptibility genes, the amino acid oxidase activator, DAOA, also known as G-evdomindavio, dysbindin, neuroregulin, and zinc finger protein, octocociosteateatarda, i.e., ZNF octocociosteateatarda, susceptibility chromosomal abnormalities, disrupted in schizophrenia in a DISC and a microdeletion of chromosome 22q11, velocardiofacial syndrome, increases the risk of development of schizophrenia. Up to 25% of individuals with 22q11 deletion will later develop schizophrenia. O neurochemistry dopamine, DA, hypothesis, postulates schizophrenia is due to excess dopamine within the mesolimbic system. This theory is based on amphetamine, a DA agonist, produces positive symptoms similar to schizophrenia. Levodopa increases DA concentrations and produces positive symptoms of schizophrenia. Dopamine agonists worsen psychotic symptoms. Disulfiram inhibits DA metabolism and worsens schizophrenia. Of the alpha and beta isomers of flupentixol, only the alpha isomer helps people with acute schizophrenia. Cis-flupentixol alpha isomer is a DA antagonist and is clinically effective. Trans-flupentixol.
Flupentixol does not have DAR antagonist activity and is clinically ineffective. Note: dopamine levels are not increased in urine or tears. Serotonin 5-HT hypothesis postulates that schizophrenia is due to serotonin overactivity. This theory is based on LSD, a 5-HT agonist, produces positive symptoms similar to schizophrenia. The newer antipsychotics act by blocking the 5-HT receptors. For example, olanzapine is a 5-HT2A receptor antagonist. 80. Glutamate hypothesis. Glutamate stimulates NMDA receptors. Phencyclidine angel dust produces both positive and negative symptoms by blocking NMDA receptors. O neurodevelopmental hypothesis. Schizophrenia is more common among people born in the winter and spring than in those born in the summer. More common between January and April in the northern hemisphere, and between July and September in the southern hemisphere. Note: one possible reason that researchers believe may explain this seasonality of schizophrenia risk is the association between winter-spring births and sunlight exposure. A lack of sunlight, for example during the shorter days of winter, can lead to vitamin D deficiency, which scientists believe could alter the development of a child's brain in the mother's uterus and after birth. The timing may also reflect seasonal exposure to viral infections. Prenatal exposure to infection, for example influenza, malnutrition or stress, are associated with an increased risk of schizophrenia. Obstetric complications, for example birth asphyxia, are associated with an increased risk of schizophrenia. Non-right-handedness, that is left-handedness or mixed-handedness, is associated with an increased risk of schizophrenia. Increased rates of minor physical abnormalities. People who develop schizophrenia show abnormalities in their development that precedes disease onset. Cognitive development. Children who later develop schizophrenia as adults have been shown to be distinguished by their peers by lower educational test scores. Increased risk for developing schizophrenia has been shown to be associated with reduced IQ. Motor development. Children who later develop schizophrenia as adults have been shown to be distinguished by their peers by delayed motor milestones and have been shown to perform poorly in sports and handicrafts compared to normal peers. Abnormalities of motor development may be reflected in the excess of neurological soft signs, that is, minor neurological signs indicating non-specific cerebral dysfunction. For example, poor motor coordination, sensory perceptual difficulties, and difficulties in sequencing of complex motor tasks. Social and interpersonal adjustment. Children who later develop schizophrenia have been shown to have worse peer relationships than controls. Premorbid symptomatology. Children who later develop schizophrenia have been shown to have a high risk of developing schizophrenia as adults if they reported experiencing one or more of the following: believing that other people could read their mind, experiencing messages that have been sent to them by the television or the radio, believing that people have been spying on them, hearing voices that other people cannot hear. Note: recent research has found that up to 20% of young adolescents can report subclinical, psychotic symptoms such as hearing voices. These symptoms can be associated with an increased risk for schizophrenia in adulthood, 8% risk, and are also associated with higher prevalence of other psychopathology such as depression, anxiety, and suicidal behavior. However, these symptoms are not always markers of psychopathology and are transient in more than half of those who report the symptoms in adolescence. It has been shown that about 5% of adults in the general population report psychotic symptoms in the absence of psychotic disorder. These findings have led to a consideration of an extended psychosis phenotype or psychosis continuum in the population. Organic factors. Positive association, increased risk with chronic temporal lobe epilepsy, Huntington's chorea, traumatic brain injury. Negative association, there is a negative association between rheumatoid arthritis and schizophrenia. Substance misuse. Adolescent cannabis use is associated with an increased risk of developing schizophrenia. A functional polymorphism in the catechol O-methyltransferase (COMT) gene moderates the influence of adolescent cannabis use on developing adult psychosis. Carriers of the COMT valine 158 allele are more likely to exhibit psychotic symptoms and to develop schizophrenia if they use cannabis. The use of stimulants such as amphetamine and hallucinogens such as ketamine, phencyclidine, PCP, and lysergic acid diethylamide, LSD can mimic symptoms of schizophrenia. Psychological factors or life events. Childhood trauma is associated with an increased risk of developing schizophrenia. Recalled sexual abuse is associated with an increased risk of developing schizophrenia. Separation from a parent for 6 months before the age of 5 years is associated with increased risk of developing schizophrenia. Compared to normal controls, people with schizophrenia may have more life events, particularly clustered in the 81. 3 weeks preceding relapse or admission. Social factors or employment status, unemployed or living situation, urban rural elevated risk with more years before age 20 years residence in urban areas or socio-economic group, increased risk in lower socio-economic groups, that is, IV and V social drift hypothesis. Affected individuals drift down the socio-economic scale as a consequence of their illness, both premorbidly and after illness onset. Social causation hypothesis. Breather hypothesis. Stresses related to socio-economic deprivation are risk, increasing or inducing factors for the development of schizophrenia or premorbid characteristics. People with schizophrenia often live alone, are unmarried and have few friends. These patterns frequently began before the illness or migration. Increased risk among migrants. For example, Afro-Caribbean migrants in UK. The risk persists into second-generation migrants. Brain abnormalities. Abnormal smooth pursuit eye movements. Paroxysmal saccadic eye movements in 50-80% of patients and their relatives. Structural brain imaging. O ventricle to brain ratio is greater than controls. O enlargement of the cerebral ventricles. O cortical volume loss. The greatest reductions are in the temporal lobe, especially the medial temporal lobe. Volume loss affects gray matter more than white matter. Widening of sulci. O functional brain imaging. Functional disconnectivity between frontal and temporal lobes. O postmortem studies. The brains of people with schizophrenia are lighter. Decrease in brain weight and smaller reduction in anterior-posterior length than controls. Reduction in neuronal population in the temporal lobes, possibly on the left. Reversed planum temporal asymmetry. Males versus females. Males are more likely than females to have or more obstetric complications or worse premorbid adjustment or more structural brain abnormalities which are associated with cognitive decline, that or negative symptoms, or worse prognosis. Men are less likely than females to get married. Fertility rates in females with schizophrenia are reduced by about 25% compared to the general population. Risk of suicide, 2%. Note, the widely held view that 10-15% of people with schizophrenia die from suicide is misleading because it refers to proportionate mortality, not lifetime risk. Nevertheless, there is a substantial increase in risk of suicide compared with the general population. Note, the risk of suicide is increased in the period following discharge from hospital. High IQ and good insight are associated with higher suicide risk in schizophrenia. Physical health. Life expectancy is significantly reduced for people with serious mental illness versus controls. Any serious mental illness, life expectancy is reduced by 13 years for males and 12 years for females. Schizophrenia, life expectancy is reduced by 15 years for males and 10 years for females. Bipolar affective disorder, life expectancy is reduced by 10 years for males and 11 years for females. Substance use disorders, life expectancy is reduced by 14 years for males and 15 years for females. Depressive episode and recurrent depressive disorder, life expectancy is reduced by 11 years for males and 7 years for females. Causes of death in schizophrenia, mostly natural causes. 1/3 cardiovascular disease, 1/6 cancer. Markedly raised standardized mortality ratio for cardiovascular disease, diabetes mellitus, chronic obstructive pulmonary disease, influenza pneumonia, increased sudden cardiac death. X2 in schizophrenia. People with schizophrenia and bipolar disorder are half as likely to get catheterization revascularization procedures after acute myocardial infarction as controls. People with schizophrenia and other serious mental illness have increased rates of smoking, alcohol use, poor diet, obesity, 82, and sedentary behavior. People with schizophrenia have been shown to have reduced bone mineral density at the hip and lumbar spine versus controls. Vitamin D deficiency has been found in schizophrenia. Low vitamin D levels plus reduced bone density plus hyperprolactinemia plus smoking plus obesity plus sedentary behavior. Fracture risk. Decreased pain sensitivity has been reported in schizophrenia. People with established psychosis have been found to be about half as likely to brush their teeth twice daily as controls. Uptake of cancer screening is reduced in people with schizophrenia and other serious mental illness versus controls. For example, women with serious mental illness are less likely to receive breast and cervical cancer screening. People with schizophrenia who develop cancer receive fewer sessions of chemotherapy and less radiotherapy or surgical intervention than controls. Prognosis. Generally, it has been estimated that for people with schizophrenia, 25% will experience a full recovery, 40% will experience recurrent episodes with some degree of social disability and periods of unemployment, and 35% will experience long-term schizophrenia, with a high rate of both hospital admission and social disability. The prognosis is more favorable in less developed countries. The reasons are not fully understood. Prominent affective symptoms are a predictor of good prognosis. Predictors of poor prognosis: O male gender, O single, O separated, widowed or divorced, O history of obstetric complications, O low IQ, O insidious onset, O younger age of onset, O low premorbid functioning, O longer duration of untreated psychosis, O negative symptoms, symptoms predominate over positive symptoms, or substance misuse or ventricular enlargement or poor response to medication or family history of schizophrenia or misuse of alcohol and or illicit substances or high expressed emotion. Note: high expressed emotion is a predictor of symptomatic relapse following discharge from hospital. Those people from families with high expressed emotion relapse more frequently than those who are from families without high expressed emotion. Components of high expressed emotion are critical comments, hostility and emotional over-involvement. Note: the risk of relapse is increased in people who misuse alcohol and or illicit substances. Note: there is an increased risk of bipolar affective disorder in families of people with schizophrenia and vice versa. Note: the rate of cigarette smoking in people with schizophrenia is higher than that of the general population. Those people with schizophrenia who smoke do so at heavier rates than the general population. 2. Schizotypal disorder, ICD-10 criteria, a disorder characterized by eccentric behavior and anomalies of thinking and affect which resemble those seen in schizophrenia. Although no definite and characteristic schizophrenic anomalies have occurred at any stage, occasionally schizotypal disorder evolves into overt schizophrenia. It is more common in individuals related to people with schizophrenia and is believed to be part of the genetic spectrum of schizophrenia. Note: although the ICD-10 diagnostic criteria for schizotypal disorder differ in detail from the DSM-IV criteria for schizotypal personality disorder, they define essentially the same condition. ICD-10 does not consider the disorder to be a personality disorder unlike DSM-IV, and it classifies it with schizophrenia, schizotypal and delusional disorders. 3. Persistent delusional disorders. A 30-year-old man has a 5-year history of believing that he is being followed by the FBI and that his life is under threat. He denied a history of auditory hallucinations and other symptoms of schizophrenia. ICD-10 criteria. This group includes a variety of disorders in which long-standing delusions constitute the only, or the most conspicuous, clinical characteristic and which cannot be classified as organic, schizophrenic or affective. One example is Ekbom's syndrome, see Chapter 16, 83. Subtypes. A delusional disorder, or delusions constitute the most conspicuous or the only clinical characteristic, or they must be present for at least 3 months and be clearly personal rather than subcultural, or there must be no evidence of brain disease, no or only occasional auditory hallucinations, and no history of schizophrenic or residual category for persistent delusional disorders that do not meet the criteria for delusional disorder. Symptoms: delusions of control, thought broadcasting, etc. B. Other persistent delusional disorders. 4. Acute and transient psychotic disorders. A 40-year-old teacher was under significant stress at work after he was promoted to headmaster 2 weeks previous. Following his promotion, he described a 1-week history of auditory hallucinations and believing that the students in the school were poisoning his food. He resigned from the job as headmaster and reported that within 2 days, he no longer experienced auditory hallucinations and ceased to believe that the students wanted to harm him. ICD-10 criteria. Acute onset. Change from a state without psychotic features to a clearly abnormal psychotic state within or less. Typical symptoms. Or rapidly changing and variable state called a polymorphic state, or the presence of typical schizophrenic symptoms. Period of 2 weeks. Associated acute stress, or the first psychotic symptoms occur within about 2 weeks of one or more events that would be regarded as stressful to most people in similar circumstances. Within the culture of the person concerned, complete recovery usually occurs within a few months, often within a few weeks or even days. 5. Induced delusional disorder. 2 sisters live together and have a close relationship. One sister has a history of believing that the FBI were following her and wanted to harm her. Her sister, who does not have a history of mental illness, reported that over the past month she too believes that the FBI are a threat to her. ICD-10 criteria. A rare delusional disorder shared by 2 or occasionally more people with close emotional links. Only one person suffers from a genuine psychotic disorder. The delusions are induced in the other, and usually disappear when the people are separated. Almost invariably, the people concerned have an unusually close relationship and are isolated from others by language, culture, or geography. The individual in whom the delusions are induced is usually dependent on or subservient to the person with the genuine psychosis. Note: this condition includes Foley Adusi Chapter 16 on other psychiatric syndromes. 6. Schizoaffective disorder. A 32-year-old woman presented with a 1-month history of believing that she is being followed by the FBI, in addition to a reduction in her sleep, appetite and energy level. ICD-10 criteria. Episodic disorders in which both affective and schizophrenic symptoms are prominent within the same episode of the illness, preferably spontaneously but at least within a few days of each other. The episode of illness does not meet the criteria for either schizophrenia or depressive or manic episodes. Subtypes. A schizoaffective disorder, manic type. A disorder in which schizophrenic and manic symptoms are both prominent in the same episode of illness. B. Schizoaffective disorder, depressive type. A disorder in which schizophrenic and depressive symptoms are both prominent in the same episode of illness. C. Schizoaffective disorder, mixed type. Disorders in which symptoms of schizophrenia coexist with those of a mixed bipolar affective disorder. Epidemiology. Males equals females. Prevalence of schizophrenia is not increased in schizoaffective families, but the prevalence of mood disorders is increased. 84. Management. Antipsychotics used in combination with lithium or an antidepressant. Prognosis. Intermediate between schizophrenia and affective disorder. That is a better prognosis than people with schizophrenia and a worse prognosis than people with affective disorders. Schizoaffective disorder. Manic type has a better prognosis than schizoaffective disorder. Depressive type. 85. Notes Chapter 14. 86. Chapter 15 Management of schizophrenia. 87. Chapter 15. Management of Schizophrenia. 1. Biological management. 2. Psychological management. 3. Social management. 1. Biological management of schizophrenia. Reference. NICE Guideline. CG 178. Psychosis and schizophrenia in adults. Treatment and management. Published February 2014. Last updated March 2014. Introduction. Choice of antipsychotic medication. The choice of antipsychotic medication should be made by the service user and healthcare professional together, taking into account the views of the carer if the service user agrees. Provide information and discuss the likely benefits and possible side effects of each drug, including metabolic, including weight gain and diabetes, extrapyramidal, including akathisia, dyskinesia and dystonia, cardiovascular, including prolonging the QT interval, hormonal, including increasing plasma prolactin, other, including unpleasant subjective experiences, how to use antipsychotic medication. Before starting antipsychotic medication, undertake and record the following baseline investigations: weight plotted on a chart, waist circumference, pulse and blood pressure, fasting blood glucose, glycosylated hemoglobin, HbA1c, blood lipid profile and prolactin levels, assessment of any movement disorders, assessment of nutritional status, diet and level of physical activity. Before starting antipsychotic medication, offer the person with psychosis or schizophrenia an ECG if, specified in the summary of product characteristics. SPCOA physical examination has identified specific cardiovascular risk, such as diagnosis of high blood pressure, there is a personal history of cardiovascular disease, or the service user is being admitted as an inpatient. Treatment with antipsychotic medication should be considered an explicit individual therapeutic trial. Include the following: discuss and record the side effects that the person is most willing to tolerate, record the indications and expected benefits and risks of oral antipsychotic medication, and the expected time for a change in symptoms and appearance of side effects. At the start of treatment, give a dose at the lower end of the licensed range and slowly titrate upwards within the dose range given in the British National Formulary, BNF, or SPCO. Justify and record reasons for dosages outside the range given in the BNF or SPCO. Record the rationale for continuing, changing or stopping medication, and the effects of such changes. Carry out a trial of the medication at optimum dosage for 4 to 6 weeks. Monitor and record the following regularly and systematically throughout treatment, but especially during titration, response to treatment, including changes in symptoms and behavior or side effects of treatment, taking into account overlap between certain side effects and clinical features of schizophrenia. For example, the overlap between akathisia and agitation or anxiety and impact on functioning, or the emergence of movement disorders. Weight weekly for the first 6 weeks, then at 12 weeks, at 1 year, and then annually plotted on a chart. Waist circumference annually plotted on a chart. Pulse and blood pressure at 12 weeks, at 1 year, and then annually. Fasting blood glucose, HbA1c and blood lipid levels at 12 weeks, at 1 year, and then annually. Adherence and overall physical health. 88. Treatment algorithm for schizophrenia. Reference: Maudsley Prescribing Guidelines in Psychiatry, 13th edition, 2018. Key points that patients should know. Reference: Maudsley Prescribing Guidelines in Psychiatry, 13th edition, 2018. Antipsychotics do not cure schizophrenia. They treat symptoms in the same way that insulin treats diabetes. Some antipsychotics may be more effective than others. Many antipsychotic drugs are available. Different drugs suit different patients. Perceived side effects should always be discussed, so that the best tolerated drug can be found. Long-term treatment is generally required to prevent relapse. Antipsychotics should not be stopped suddenly. Psychological and psychosocial interventions increase the change of staying well. 89. Efficacy. Further to the publication of the Clinical Antipsychotic Trials of Intervention Effectiveness, KT study, and the cost utility of the latest antipsychotic drugs in schizophrenia study, Cutlass, the World Psychiatric Association reviewed the evidence relating to the relative efficacy of 51 typical antipsychotics, which are also known as first-generation antipsychotics, FGAs, and 11 atypical antipsychotics, which are also known as second-generation antipsychotics, SGAs, and concluded that, if differences of extrapyramidal side effects, EPSEs, could be minimized by careful dosing and anticholinergic use avoided, there is no convincing evidence to support the advantage for SGAs over FGAs. As a class, SGAs may have a lower propensity for EPSEs, but this is offset by a higher propensity for metabolic side effects. SGAs may be superior to FGAs in treating negative symptoms. Both FGAs and SGAs treat positive symptoms. FGAs still play an important role in schizophrenia and offer an alternative to SGAs when SGAs are poorly tolerated or where FGAs are preferred by the patients themselves. Clozapine has superior efficacy in the treatment of schizophrenia over other antipsychotics. Types of antipsychotics. Class of agent: first generation antipsychotics. Group: butyrophenone, benzamide, diphenylbutylpiperidine. Example: phenothiazine, chlorpromazine, promazine, trifluoperazine, flufenazine depot. Typical: thioxanthine, flupenthixyl depot. Note: flupenthixyl has some antidepressant effects. Zaclopenthixyl depot. Second generation atypical that substituted benzamide, haloperidol, sulpiride, pimazide, amisulpride, olanzapine, quetiapine, risperidone. Antipsychotics. Third generation antipsychotic, also an atypical antipsychotic: phenobenzodiazepine, dibenzothiazepine, benzizoxazole, phenylindole derivative, dibenzodiazepine. clozapine, which itself is an atypical antipsychotic, Certindole, clozapine, paliperidone, the main active metabolite of risperidone, aripiprazole. Note, the threshold for antipsychotic efficacy is more than 65% D2 receptor occupancy. D2 receptor threshold applies to all antipsychotics. Note, the threshold for raised prolactin is more than 72% of D2 receptor occupancy. Note, blocking more than 78% of D2 receptors produces EPSIS. This applies to both typicals and atypicals. Note, high 5-HT2A antagonism is not protective against EPSIS. Effects of D2 antagonism. Mesolimbic pathway. Antipsychotic efficacy is mediated by antagonism of D2 receptors in the limbic striatum. Mesocortical pathway. Deterioration in cognitive function. Nigrostriatal pathway. Parkinsonism daughter EPSIS. Tuberoinfundibular pathway. Hyperprolactinemia. Compliance. Poor compliance is particularly a problem with schizophrenia. The risk of relapse in 2 years for someone with schizophrenia who stops their prescribed antipsychotic medication is approximately 75%. Factors associated with compliance in schizophrenia. O attitudes, O insight, O side effects of medications, O the presence of negative symptoms, O poor psychosocial support network, O poor access to care. 90. Benefits of antipsychotics. Antipsychotics may be able to affect the natural course of schizophrenia or repeated relapse of